Thank you, and good morning, everyone. Welcome to our Board of Health meeting today. Members of the public are advised that our meetings are webcast live by the City of Hamilton and temporarily archived on the city's website. All electronic devices are to be switched to a non-audible function during our council meetings, and members and delegates are reminded of the 5-minute time limit, which will be adhered to during this meeting. Members can submit another request to speak if they require more time to ask questions or make comments. I'm going to turn to a roll call for your attendance, and I'll start with Councillor Wilson.
Good morning.
Good morning. Councillor Farr.
Good morning, Mr. Mayor.
Good morning. Councillor Nan.
Good morning, present.
Good morning. Councillor Marula.
Good morning, Mr. Mayor. Present.
Good morning. Councillor Collins.
Here.
Thank you. Councillor Jackson.
Good morning, Your Worship.
Good morning, Councillor. Councillor Pauls.
Present.
Thank you. Good morning, Councillor Danko.
Good morning, I'm present.
Good morning. Councillor Clerk.
Good morning, sir.
Good morning. Councillor Pearson.
Good morning, Mr. Mayor. I'm here.
Good morning. Councillor Johnson.
Good morning.
Good day. Councillor Ferguson.
Good morning.
Good morning. Councillor Vanderbeek.
Good morning, sir.
Thank you. Good morning. Councillor Partridge.
Yes, good morning. I am here.
Good. Oh, we're all present and accounted for. Thank you. Madam Clerk, are there any changes to the agenda, please?
Yes, Mr. Mayor, we have the following additions to the today's agenda. It's correspondence item 5.1 from Mel Switzer, President, Hamilton Wentworth Federation of Agriculture, and Drew Spolstra, Vice President, Ontario Farmers Association, respecting support for agricultural workers and food processors as a priority vaccination group. We have added item 5.2, correspondence from Peterborough Public Health respecting appreciation and support for the province's decision to extend the current stay-at-home recommendation, stay-at-home order. And we have additional delegation request 6.1, delegation request from Kate Mulligan, Toronto Board of Health member, respecting reformation of the Hamilton's Board of Health for today's meeting. Emily Power, respecting the urgent need for a more proactive strategy to address COVID-19 outbreaks in apartment buildings for today's meeting, and David Elfstrom, respecting COVID-19 outbreaks in apartment buildings. And we have a delegation request that has been withdrawn by Terry Bedminster of Refuge Hamilton Center for Newcomer Health. So that has been withdrawn.
Okay, thank you. So can I have a motion to approve the agenda as amended, please? Moved by Partridge, second by Councillor Nan. Thank you. All in favor? We'll require an electronic vote.
Sorry about that. That was the one vote that I did not add, but here it is.
Well, we'll give you all the time you need to do that.
Councillors Marula and Collins should be able to vote now. Taking them off the list. Councillor Marula?
It's not appearing. I'm in the actual e-scribe, but it's not appearing, but I do support it accordingly.
Thank you very much. I'll have it cleared up by the next vote.
Thank you.
And the vote count on that, Madam Clerk, is?
Carried 15-0, sir.
Thank you. Members of council, any declarations of interest? Not seeing any waving of hands or otherwise, so thank you. Those who've, no one's noted a conflict. May I have a motion to approve the minutes of April the 19th as presented, or unless there's questions? Moved by, thank you. Seconded by Farr. Any questions on the minutes? Hearing none, thank you. Electronic vote once again.
That will be just one moment.
Yep.
And the vote is open.
Thank you.
Excuse me, Mr. Mayor, through you to Madam Clerk. It's not appearing, so perhaps I need to reboot for
Probably.
it to appear. Okay, so I shall do that.
Or Control F5. Sometimes
okay, thank you. Thank you.
That'd be a refresh, which sometimes works, yeah. So as Councilor was doing that, Madam Clerk, that was approved.
Yes, and that also carries 15-0.
Thank you. We have two communications items. Members of council, would you like to speak to any of those? Councillor Partridge.
And I've activated the speakers list.
Thank you. Yes, good morning, Mr. Mayor. On 5.1, I'm wondering if I could get an update, please. This 5.1 is from Mel Switzer, President of the Hamilton Wentworth Federation of Agriculture, and also from Drew Spoolstra, who is Vice President of the Ontario Farmers Association. And just where are we with the prioritizing the migrant workers? Because certainly I'm hearing from my farmers up here as well that it is an issue. Please.
Thank you. Dr. Richardson?
Through you, Mr. Mayor. The migrant farm workers are a group we've been working with extensively over the course of the pandemic. And so there's both the IPAC work that's been done, and they were all re-inspected again this spring for those that go into spring processing and farming. With those that happen later in the year will be done a little later in the year. But when it comes to the vaccination program, we've been working with all of those that do have migrant farm workers on farm in terms of setting up clinics. And in fact, I believe those ran this weekend at Ancaster Fairgrounds and at Harry Howell in terms of vaccination for these groups. And anybody who works on the farms was eligible to come forward to those clinics, and they were arranged directly with those farms. For anybody who's not part of the migrant farm worker program or the temporary farm worker program, they are eligible now through the provincial portal to book through that route, and that was opened up last week as well. And there's no, in terms of the prioritization, we are working through the priorities as they're set out by the framework and as they're opened up. And then they're able to access any of the appointments at any of the locations that are there on that system. I'll just turn to Michelle to see if there's anything else in terms of a more recent update on that front.
Thank you.
Thanks, Dr. Richardson. No, there's not much of an update other than to say, yes, the farmers were completed this weekend. Overall, very positive response. We heard from the farmers on site at the clinics this weekend that they were happy that it rolled out in this way. And so that piece of work is completed from a vaccine status.
Thank you. So my question, when you say that the vaccination of migrant workers is completed, does that mean that all of the migrant workers on the farms are all now vaccinated, or does it mean just those who came to the clinic are vaccinated?
Through you, Mr. Mayor. So yes, just the farmers that came to the clinic. However, all of the farms were offered the opportunity to come to the clinic this weekend. The other piece is that some of our migrant farmers, of course, receive vaccine upon arrival at the airport. And so that piece of work is finished as well. I don't have for you exactly, Councillor, what the percentage of non-vaccinated farmers are at this point, but everyone's certainly been offered the opportunity to receive vaccine, and we'll offer that opportunity again.
Yeah, I appreciate that, Michelle. And actually, if it's not too much trouble, I would appreciate those numbers offline. Because it's extremely busy right now on the farms, just with spring planting and trimming and pruning, and there's so much going on. And of course, it's in some cases it's a 24/7 operation, depending on which farm operation they're on. And Elizabeth, just one more question. You mentioned at the beginning of your explanation the term IPAC. For those watching who have no idea what that means, could you please give an explanation?
Thanks, Councillor. You're quite correct. We tend to use these acronyms and fall into them all the time. So this is the infection prevention and control inspections that are done to look and make sure that, for example, the housing is well arranged, that they have the proper PPE, that they're distancing appropriately on the farms in their work and housing. All of those sorts of assessments are made.
Thank you. I appreciate that. Thank you, Mr. Mayor.
Thank you. Councillor Vanderbeek?
Thank you, Mr. Mayor. Through you to Dr. Richardson. I'm wondering if you could elaborate a bit, because this letter deals with more than migrant farm workers. It deals with the farm workers who leave their homes and come to the farm, that live in Canada and always live in Canada. So seasonal workers, people who only work on the farm at certain times of the year. It also deals with workers in food processing plants, with a concern about Section 22. If there's a food processing plant that has an outbreak that meets Section 22, food production stops. Therefore, produce has nowhere to go. So this is a question of prioritizing. So I do understand that the migrant workers have been prioritized. Farmers can apparently go to the clinics because they can't work from home. Is it indeed the farm family that can't work from home that will be allowed to go to the clinics? And in addition to that, how are we communicating to the farmers, to the farms in our city, what is available to them and what the priorities are?
Thank you. Doctor?
Through you, Mr. Mayor. So there's sort of two aspects to our work with farms and with food production overall. So the piece with the migrant farm workers is one where we have a specific role that's laid out in the standards in terms of inspecting housing, making sure that things are running well there. And so that is the group with whom we have an ongoing, you have a list of who they are. We can contact them every year. We have an ongoing relationship with them from both that infection prevention and control standpoint, but also with the vaccine program as it's been rolled out. The other group of farmers who don't have temporary farm workers that fall into that program or who are in food production would be the groups that we communicate just with, as with all businesses. We've been working through the chamber, we've been working through media, we've been social media, all of those sorts of routes in terms of communicating information. And of course, that's not just by Hamilton Public Health, but also by the province and others. So when we speak about vaccination and what you heard about the migrant farm worker program, all of those who work on those farms are eligible for vaccination through those clinics and those routes. So we don't differentiate between, who's in which group. There, all of those people are eligible. For those who are farms or landscaping businesses or whatever they may be that don't employ any of those sorts of workers, their access to information and would be through those other routes, media, social media, all of those pieces, and similarly across all of our food processing piece. And so within the prioritization that was set out by the province, there were two different groups of essential workers. And by and large, those in the agri-farm workers and the food processing groups fell into essential group 1. And so we're eligible a couple of weeks now ago. So they are able to go through, book appointments for vaccination and would be booking through our main clinics in terms of getting there. In terms of other sorts of access points, which I think is what you were asking about, Councillor, were you asking about other pieces for that group? If not, I'll go on to the Section 22 question.
Yeah, no, I just wanted to clarify for those who may listen to this about how a farm family, their kids who might be 18 and more can get vaccinated with some kind of priority, or at least even if that priority has been met, but to explain how they can be vaccinated as a farm worker, as a farm owner, as a farm family who are working on the farm. Part of the concern in this letter is about getting the word to the farmers. And about being sure that once they've harvested their crop, it's going to be able to be processed so that those workers in the food processing plants are prioritized as well. So I'll go back to you, and certainly you can talk to Section 22, and then I'll have another question for you.
Right. And so, as I said, we've gone through business routes, we've gone through media routes, we've gone through various routes to try and get the messages out about prioritization as we go forward. And the province is, of course, doing that as well. The Ministry of Labor does. Everybody is trying to get messages out through the various routes that we have to access those groups. When it comes to then processing the food, once it's been farmed, those food processing workers are, again, part of that essential service workers group. And so they have been prioritized, able to go online to book an appointment. Of course, anybody who has a challenge in doing that has been able to call our hotline as well. And I'm pleased to say the number of calls had dropped off towards the end of last week, so getting through was easier, or call the provincial hotline to make those bookings. And then when it comes to actually working through any issues in those plants, the Section 22 order, I'll just remind people, for when we put this piece out, there were sort of two key initial pieces that this was for. So the first was to make sure that we were notified if there were cases that were happening in these businesses. So we asked them to notify us if they had 2 cases, and we asked them to notify us again if they had 5 cases. And the reason for that is twofold. One is just with the sheer volume of cases, you saw from our performance statistics that it was difficult for us to keep up and get to every case within 24 to 48 hours, which is the standard we would want to meet. And so if there were cases that were happening, we wanted them to tell, and they were aware, we wanted them to call us and make us aware. At the same time as well, people who work in these areas don't necessarily live in our jurisdiction. And so the timeline for us to get notified about those cases could be longer than it was for them who are working directly with these individuals. So again, asking them to notify us so we were aware quickly that that was happening. And then once we had that notification, working with those sites, making them aware that closure may be something that might need to happen, along with a whole suite of other control measures that we put in place. But essentially, that we work through with those sites what is going on, what the challenges might be that they're having around control in those settings, and if absolutely necessary, moving to closure, partial closure, shift closure, whatever it may be. We've had very good success with all of the businesses that we've been working with in terms of outbreaks. By and large, the work is done voluntarily. Many of them have already done it. By the time we talk to them, they have gotten more and more information and understanding of what to do. And so, for example, they may send a group of workers home or whatever it may be, but manage to continue in another way that's very safe. And so we work with them through those challenges if they experience them. Bottom line is, if they need to close in order to prevent transmission, that might be something that does need to happen, but it's definitely a last resort and definitely done very thoughtfully in collaboration with the organization.
Thank you. Councillor
Thank you,
Vanderbeek.
Dr. Richardson. And is my time up, Mr. Mayor?
Pretty much.
Okay, can I just ask one more question? It's a quick
Yep.
one, and I don't think it'll be a yes or no. And so, Dr. Richardson, through you, Mr. Mayor, to you, Dr. Richardson, one of the things they're asking for is the opportunity to help. And so the Hamilton Wentworth Federation of Agriculture I'm talking about in this letter. And so I'm wondering whether you could commit to reaching out to them and utilizing their membership, their access to their membership to get the message out to the farmers, at least in Hamilton. I mean, the Ontario, there's the OMAFRA, there's also an Ontario version, which the province could use if they're not. I'm not going there, but but you are involved with them. But I am asking if you could please just reach out to Hamilton Wentworth Federation of Agriculture and seek the ways that you can help to get messages out to the farming community. They are a very large sector of our economic viability here, and we all like to eat. So, so thank you.
That was a long, quick question.
Yeah, I know. I'm sorry.
Dr.
I'm done. Thank you, Mr. Mayor. I
Thank you.
appreciate your
Thank you. Dr. Richardson, answer to that?
Through you, Mr. Mayor, absolutely, Councillor. We'd be happy to.
That was a yes. Okay.
That was yes or no?
Yeah, that was a yes.
That was a long yes.
No, that's not what I meant. The question was long, but the answer was short.
Yeah.
Anyway, thank you very much.
All right. On item 5.1, other speakers on item 5.1, are we still on that topic? Councillor Nan?
Good morning. Thank you. Yes,
Morning.
just wanted to follow up from the questions previously asked. Dr. Richardson or Director Baird, on the vaccine pop-up that happened this weekend targeting farm workers, how many vaccines did we administer through the pop-up?
Through you, Mr. Mayor. So just over 150 vaccines were administered this weekend to the farm workers, and that includes both the migrant farm workers, the temporary farm workers that are here, as well as the farmers who work on those farms.
Thank you.
Thank you. And then on the piece previously about the percentage of total population who fits that demographic priority group being vaccinated, could that just get rolled into our ongoing vaccination rate updates? I think it was previous Board of Health, we had discussed including equity and or priority populations, so we can just measure consistently as a Board of Health how we're performing in getting those populations vaccinated.
Through you, Mr. Mayor.
Public health, you mean? Thank you. Michelle?
Sorry, yes, public health, sorry.
Yes, through you, Mr. Mayor. You may recall in one of the recent updates, I'd mentioned that the ability to separate out specific separate groups is almost impossible at this point because of a couple of factors, but mainly because the information that's collected at the time of vaccination, there may be multiple reasons why somebody gets vaccinated. I could be an essential worker, I could have a chronic disease, I may meet an age bracket. There may be many different reasons why I could be vaccinated, but only one of those can get entered as the reason that I was vaccinated. And so our data to be able to separate all those different groups is becoming unable to be found. We were able to do it at the beginning because of for example, with the healthcare workers, because of the way we were registering them. But now at this point, and with the experience with the vaccine information system, that's not possible to track at this point. So we're able to give vaccinations by age as well as FSA, but to give any more detailed information, and you'll know, for example, for long-term care homes and retirement homes, we had done a special census of those two types of facilities back at the end of February, beginning of March, so that we could give some information in that regard. And it was challenging enough to get accurate information at the time. And of course, as things transition and change and new people come, it just can't be kept up with. And so the province is looking for ways that they can do some of that, and they continue to do some of that. But essentially, we're down to being able to report based on age and area of the city.
Thank you.
Thank you.
Councillor Net.
And then last question on that one. So are we intending to do another farm workers pop-up clinic down the line? And if so, I guess the only data we're able to collect is based on the number of vaccinations we administer through that pop-up clinic.
Thank
Through
you.
you, Mr. Mayor, as we go forward, we may well do another clinic. It depends on what we find. With our workers being vaccinated increasingly through the airport, that's a great route. They get their first dose, and then we'll look at what do they need for more first doses and what do they need for second doses if they're still in country. So as we work with the farms in terms of what the needs are, then we'll make decisions about what to do from there.
Thank you.
Thank you. Councillor Wilson.
Thank you. Councillor Nan covered my questions on method. Thank you.
Okay, thank you. I see no further speakers on communications item 5.1. Can we, everyone okay to receive this communication then? Thank you. I'm going to go to 5.2, correspondence from Peterborough Public Health. Anyone want to speak to that? Not seeing anyone. So on the communications items 5.1 and 5.2, all in favor then?
Mover and a
Councilor Mann,
seconder, please.
Was that in favor? Move Pearson, seconder Nan. Thank you.
Coming right up, sir.
Brilliant.
Vote is open.
Thank you. Councilor Marula, you're back dialed in, refreshed and rebooted. If you were speaking, I couldn't hear you.
And Councillor Collins?
Yes, Mr. Mayor, sorry.
Good.
Yes, it's not appearing for me, and I am on eScribe. I did reboot it, so I'm just going to give you thumbs up or thumbs down accordingly. Okay, thank you.
Very good. We'll keep an eye on it. Thank you.
Mr. Mayor, that carries 15-0.
Thank you. And we have three delegation requests today, 6.1, 6.3, 6.4. I have a motion to approve, or what is your wish? Councillor Wilson to move, seconded by? Councillor Nan, thank you. All in favor then?
Vote.
Thank you.
That carries 15-0.
Thank you. And as defined by our governance committee, we have made a change in terms of the order of presentations and delegates. So presentations go first and delegates go second. And I'm going to turn to Dr. Richardson on item 8.1, the COVID-19 activity in the city of Hamilton. Dr. Richardson.
Thank you, Mr. Mayor. I'm just going to start sharing the PowerPoint. There we go. If our test went well, I think you should be able to see that now.
Mm-hmm.
Great. And I'm just going to turn off my video. As you know, we've had problems with my internet in the past. So now you've seen me, you know I'm here. I'll just turn it off and go from there. And let me know if there's any challenges today as we go forward. If there is a problem, Michelle is all set to take over and finish off the presentation with my other presenting partners, just so you know. Today, there are a number of speakers. Normally, you're used to hearing from myself and from Stephanie Hughes, who's one of our epidemiologists who goes through our epidemiology. Ruth Sanderson, who's another epidemiologist who has joined us working on the SCARSN project along with our health care partners, was going to present today, but we had a total of 5 presenters, so we're taking it down to 4. So she will be available to answer questions. I'll go through our SCARSN slides. Michelle is going to present a bit about our experience with the outbreaks in the apartment buildings, and as well, Jen is going to talk more about our vaccine program and the health equity approaches there. So I will start us off. Now let's see, why are the slides not moving? This always takes me one more moment. My screen's in the wrong mode. There we go. All right. So as usual, I'll start you off with an overall piece about both the state of affairs right now in Hamilton around the COVID pandemic and our disease experience, and then talk a little bit about our vaccine rollout. And then, of course, we'll go through this in more detail, but it just gives you a sense of what's coming before we go there. So COVID-19 case activity is trending downwards from the peak of wave 3. We've been talking about shoulders. You may have heard us use that term because it's not rapidly dropping, but it is trending downwards. The SCARSN forecasting that we have been doing and that you've heard about over the last presentation here at the Board of Health and a media briefing that had happened before that, it does predict that case levels in Hamilton will continue to be over that 40 cases per 100,000 population per week, which is the threshold for the red control zone, that will continue to the end of June. So the decline is slow predicted to be slow based on the experience that we've had over this next month and a half. As of May 14th, which was last Friday, there were 232,000 doses that were administered to people in Hamilton, and 45.1% of our population has been vaccinated. Of course, that's gone up over the weekend with ongoing vaccination clinics, and you'll get updated numbers again later in the week. Our new landscape of vaccine rollout, there is now more supply available to us and available across the province. As you know, we've just been in a period where 50% of the total supply in the province has been going to hotspot areas. Most of those are in Toronto, Peel, and York. And a couple of those L9C and LAW forward sortation areas or of the postal code, those parts of the city that have those postal codes have been receiving, we've had extra doses allocated to us for those as well. We're continuing to we're advising people to continue to follow public health measures because it's very important, even for those who have been vaccinated, as we go through this time period where case numbers continue to be high and as immunity builds in those who have been vaccinated. And we do need to continue to assume that the virus is out there throughout our city, and so taking those measures at all times. So with that, I'm going to turn it over to Stephanie Hughes. As I said a minute ago, she's one of our epidemiologists, and she regularly presents here, and she will take you through here. Steph, just tell me when you need those slides changed.
All right. Thanks very much, Dr. Richardson. And good morning, everyone here. So before I proceed with my usual case summary portion, I would like to remind everyone, as I usually do, that these data are accurate as of last Friday morning. So this graph will look familiar to you as we have looked at similar graphs in previous Board of Health meetings, This graph displays the number of COVID-19 cases reported to Hamilton Public Health Services per day. Here I have displayed only wave 3 data, so looking at COVID-19 activity levels from February 17th, 2021 until May 14th, 2021. As you can see in the graph, case activity is now trending downwards, as Dr. Richardson did just mention. As of last Friday, the average number of cases reported per day to Hamilton Public Health was 120. At the peak of wave 3 in mid-April of 2021, 170 to 180 COVID-19 cases were reported to Hamilton Public Health on average per day. Dr. Richardson, if I could ask you to thank you very much. So this slide will also look familiar to you, as we've looked at similar visuals in previous Board of Health meetings. For this Board of Health meeting, I've compared the pre-peak period of wave 3 on the left to the peak period of wave 3 on the right. Although our case activity has now started to trend downwards, as I mentioned on the previous slide, that is a new trend. So up until early last week, our cases had been maintaining at the peak for a number of weeks. Therefore, I have not created a post-peak period on this slide just quite yet. So one very important number to note on this slide here is the total number of COVID-19 cases reported in both periods. So in wave 3 overall, 9,170 cases have been reported to Hamilton Public Health Services. This is greater than the total number of cases reported during the entirety of wave 2. Furthermore, the number of outbreaks declared has remained high throughout the pre-peak and peak periods of wave 3. There were 131 outbreaks declared in the pre-peak period and 108 outbreaks during the peak. It is also important for me to also highlight that the number of cases associated with outbreaks increased notably during the peak period of wave 3. I'm highlighting this now because I focused many of my slides today on our outbreak cases and activity. The number of individuals hospitalized has also remained high throughout the pre-peak and peak periods of wave 3. There were 303 individuals hospitalized in the pre-peak period and 258 individuals hospitalized in the peak period. And lastly, the majority of cases reported to Hamilton Public Health are now variant cases. So this is approximately 75%. This past Friday, we reported our first case of the B1617 variant on our Status of Cases webpage. This variant is sometimes referred to as the variant initially identified in India. Dr. Richardson, if you could change. Oh, I think it's... Oh, thank you very much. So this slide here shows the average number of hospitalizations and deaths by day, comparing both waves 2 and 3. So the intention of this slide is to show the difference in our severity indicators in the two waves. The gray line represents the average number of hospitalizations, and the orange line represents the average number of deaths. There has been a decrease in the average number of deaths reported in wave 3 in comparison to wave 2. In wave 2, at its highest, there were close to 4 deaths occurring per day. However, in contrast, in wave 3, this has remained closer to 1 per day and has not been greater than 2. The average number of new hospitalizations has remained roughly the same in waves 2 and 3. In wave 2, at its highest, there was an average of 10 new hospitalizations reported per day. Similarly, in wave 3, at its highest, there was an average of 10 new hospitalizations reported per day. And you will recall, as I presented in last month's Board of Health meeting, the age of those individuals admitted to hospital has shifted during wave 3 to a younger demographic. So the majority of individuals hospitalized in wave 2 were aged 75 plus, whereas the majority of individuals hospitalized in wave 3 have been aged 40 to 74. Dr. Richardson, if I could thank you very much. So this slide shows our overall case activity in wave 3. broken down by type of case. So this is where I'd like to bring us back to the increase in outbreak cases we've experienced at the peak of wave 3 that I touched upon in my phases slide. So here I've graphed the average number of cases reported to Hamilton Public Health per day, separating cases not associated with outbreaks out from cases associated with outbreaks. So the orange line at the top represents cases not associated with outbreaks, while the yellow line at the bottom represents cases associated with outbreaks. And the data above span all of wave 3, so from February 17 to May 14th of 2021. And what I'd like to point out here is the average number of non-outbreak cases has been decreasing since the peak of wave 3 in mid-April. And this is in contrast to outbreak cases, which have been increasing since the peak of wave 3. Dr. Richardson, if you could move to the next slide. Thank you. So this graph shows the number of COVID-19 outbreaks declared by type of setting in waves 2 and 3. The blue bars span September 1st, 2020 to February 16th, 2021, so that's wave 2. And the orange bars span February 17th to May 14th of 2021, so it's wave 3. There have been several changes in outbreak facility types when comparing the two waves. So for one, there's been a dramatic decrease in the number of outbreaks declared in long-term care and retirement homes in wave 3. This is largely a result of our vaccine rollout. There has also been a noticeable increase in the numbers of COVID-19 outbreaks declared in workplaces and schools and daycares in wave 3. Wave 3 has been particularly affected by a large number of workplace outbreaks. Of the 239 outbreaks declared in wave 3 thus far, 89, so 37%, have been in workplaces. Dr. Richardson, if you could move to the next slide, thank you. So this pie chart here shows the percentage of total cases reported to Hamilton Public Health in wave 3 by source of acquisition. So on the previous slide, I mentioned that wave 3 has been particularly affected by a large number of declared workplace outbreaks. So therefore, the intention of my graph here is to show what percentage of our overall cases in wave 3 have been associated with these declared workplace outbreaks. As you can see in the chart, so that's the yellow slice, cases associated with workplace outbreaks make up approximately 7% of all cases reported to Hamilton Public Health in wave 3. And this is in comparison to cases associated with all other outbreaks, so non-workplace outbreaks, which make up 12 to 13%. The largest proportion of cases reported to Hamilton Public Health are a result of direct contact with other cases of COVID-19, and this is 50% of all of our cases. And Dr. Richardson, if you could just move to my last slide. So here I wanted to break down the types of COVID-19 workplace outbreaks that have been declared the most often. So I have made a pie chart breaking down the settings of workplace outbreaks in wave 3. So again, February 17th to May 14th of 2021. There were 89 workplace outbreaks declared in total during this period. Of the 89 workplace outbreaks declared, the largest proportion was in the warehousing, distribution, manufacturing, and construction sector. This is consistent with our previous analyses, as well as when I presented a similar chart to you in the February Board of Health meeting. Since February, it is worth noting that there has been an increase in the percentage of outbreaks declared in the food and beverage sector and a decrease in those declared in the retail sector. And with that, I'll pass it back to Dr. Richardson.
Thanks so much, Steph. I'm actually going to pass it over to Michelle Baird, and she's going to talk to the outbreaks that we've experienced in apartment buildings in recent weeks. Michelle, over to you.
Thank you. So these recent outbreaks that we're experiencing in apartment buildings at 235 Rebecca, 125 Wellington, and 50 Cathcart, we really are considering that one building, and then of course 151 Queen. are examples of how systemic gaps and health equity is impacting COVID in these environments. If you look at these apartment building outbreaks right now, approximately 2/3 of the cases across these 3 outbreaks have acquisition within households. And among these outbreaks, we are also seeing cases originating from other outbreaks, including within essential workers. And so this is where the SDOH impacts are playing out in these apartment buildings. Okay. The COVID-19 pandemic, as we know, has exposed long-standing structural drivers of health inequities. In these buildings, we're seeing things such as precarious housing, adverse working conditions, precarious employment overall, and just challenging housing situations. The social determinants of health are playing out within these apartments and other living locations, and such as this, it really is exacerbating the impacts of COVID-19 and how COVID is transmitting within these buildings. So although public health measures and IPAC measures, they do work and the stay-at-home order is still in place, it's very challenging to maintain such measures in these settings. Many residents who live here, in fact, are part of our essential workforce, and they rely on family and friends for childcare, elder care support, help with groceries, and etc. So they're unable to remain at home, and so minimizing contact overall is a challenge. As Steph noted, the largest proportion of our outbreak cases right now is among the warehouse, distribution, manufacturing sector, and this is very much where the essential workers living in these buildings are working. And because they're relying on childcare and childcare settings, we're also seeing case activity there. It's just really impacting how COVID is being acquired among the residents here. From a testing and case perspective, I realize that it does seem at this point in time that the incidence of COVID in this neighborhood seems to be higher than in other parts of the city. And I did want to talk to you a little bit about that. This is really being amplified because as part of our COVID outbreak response here, EMS conducted mass testing for us across all 3 of these buildings, which resulted in just over 1,100 COVID tests completed. Of the cases that are residing in these buildings, approximately 50% are asymptomatic and were identified through this mass testing initiative. So outside of this outbreak, this number of individuals at these residences wouldn't have been tested. And of course, it's great that we identified these cases and the public health measures are in place to reduce further transmission. But if we were to conduct this level of testing across the city, we would very much see higher numbers elsewhere as well. And since normally asymptomatic cases, unless they're a contact of a known case, aren't tested, you can see where the numbers here are being increased dramatically through the testing initiatives that we have underway in this building. Once again, though, the testing that's happening here, the case activity we're happening here is very much reflective of what we're seeing with high case activity in the community at this point in time. The Rebecca Towers outbreak response was our first declared outbreak in an apartment building, and so we're a little bit ahead on that one with respect to the work that's happened, particularly on the vaccine front. So you'll know that we had vaccine appointments available to clients over the weekend, and our vaccine ambassadors were on site Friday to support individuals. Really, their role is to work with the individuals, work with communities to overcome barriers to receive vaccine. So 41 residents did receive vaccine at the First Ontario Centre Clinic over the weekend, while another 28 individuals were offered vaccine through the homebound work that EMS and primary care does. And I say offered vaccine because there were challenges on site with people who, you know, changed their mind when they were on site. Some people weren't at home. All of this is not uncommon. When we have our mobile team working with the homebound population, this is very much what they find on site. And so it is a resource intensive strategy. Overall, with these particular apartments, I just wanted to really talk with you and point out how social determinants of health are really playing out within these buildings, allowing for transmission within families. If we look at the buildings impacted overall, if we look at Wellington, for example, 125 Wellington, there are 41 cases there across the two buildings. But in fact, 19 of these 19 units make up the cases because the transmission is really happening within families, within close living quarters, across families supporting each other with childcare, as noted. So really what we're seeing is close living quarters, housing density, and as a result, really transmission of COVID probably beyond what we're seeing perhaps elsewhere. And that's really all I have on these apartment building outbreaks.
Thanks, Michelle. I'll pick it up again and talk a little bit about the SCARS and forecast before we go to talk more about vaccinations. So you'll remember that that the group of healthcare partners across the Hamilton Health team decided to look into using this this company to do some forecasting for us, and they are have gained more and more understanding in terms of doing this work, and have increasingly been able to base it on our own data as opposed to data from the provincial totals or from York Region, where they have also been working. And so at this point, they are very much using our own data. And then they look at sort of a base model of what is expected to happen using some assumptions that are made at the time of doing that forecast. And they're generally doing a forecast about once a week for us. And then we ask them to build in some additional sorts of scenarios that might be things that are being looked at in terms of control measures and that sort of thing. So this sort of forecast was done last week, about Tuesday, I believe it was, in terms of when they sent it to us and could discuss it further with the group that is supporting this from across all of the healthcare partners. And so you may see some things and say, okay, but things have changed from then. For example, about the stay-at-home order being extended. And so this was, of course, predated announcements about when it might be extended, and so used some assumptions that were present at the time. So overall, again, just in what we see here, and I'll go through the details, what we are seeing is that mobility levels do continue to increase despite the stay-at-home order being in place. Case levels in Hamilton are expected to be above, based on this forecast, the 40 weekly cases per 100,000 population at the end of June, which is above the red control zone that is currently used in the framework. And the timing of school reopening and the lifting of the stay-at-home order does affect the case counts, and to a smaller degree, a much smaller degree, the number of hospitalizations and deaths. So this slide shows the idea of how we're doing in Hamilton compared to other health units. So Hamilton is the black line that you see through the middle of these different curves. And you'll see the shape of that downward curve from the peak and that shoulder that we've been talking about as we've been continuing downward. And so this is not forecasting. These are actual case counts that have happened over the last last many months. And this downward decline from the peak is similar across most of the selected health units that you see here. But each one experiences it slightly differently. So the top line, the blue line, is Peel's, and we know their case rates have been very high. Toronto is here and is very similar to Durham, for example, who's in the light blue, or Green, that is York, which is the green line. And for none of these health units, none of our rates are anywhere near what they were before the beginning of wave 3. And so this has been a challenge both on the case front in terms of not getting down to pre-wave 2 levels, but as well, it has been a problem on the hospitalization and ICU front, because we do know that hospitalizations and ICUs are lasting longer, and we're not getting down to levels that we're seeing before the pandemic. This graph shows the degree of mobility. And so this is the piece we were talking about. And the very top of the graph, it's, Ruth uses the example of it being like a lake. And so if you think of that top bar is what the level of mobility was before the pandemic. And then over time, these are the decreases from that level that we have seen associated with various measures. And this shows just this time from March through until now in May, and then forecasts what it might look like into June and July. And so the orange line is what has actually been experienced. And then where you see that orange line stop, that's forecasting from there based on what might happen. And so you can see that our mobility levels have come down with the control measures that have been put in place, but they are increasing despite the stay-at-home order. And are expected to continue to go up as that order, for example, stops or as things reopen. Here is our actual base forecast. So this is the forecast of what's expected to happen, and based on those assumptions that the stay-at-home order lasted till May 31st, and that schools actually stayed closed until the end of the year, that were online learning only. And you can see that we continue to be driven here with higher numbers of cases predicted, largely driven by those in the 20 to 59-year-old age group, and predicting through June, through the month of June, that we'll stay above that red control zone level. In June, we're saying we may be at about 80 to 100 cases per 100,000 population per week. And to be within the red control zone, we would have to be down to 5.7 daily cases per 100,000, which is where this line is. So we did do 3 scenarios that were used in terms of the forecasting that was done last week. One was to look at opening schools back up early. And so they used the date of May 17th, which would be about today, of course, but would be an earlier opening. And then they did another forecast, which was opening up the schools on May 31st. And as you know, there's been a lot of discussion and concern about the impacts of schools not being open. You hear that from our pediatric colleagues, childcare colleagues, education colleagues, mental health colleagues, in terms of the impacts that are both seen on a daily basis for kids, as well as measured in our hospitals and their emerge department visits and visits to mental health specialists and whatnot. And so we modeled what different school opening might look like. So here you see the figure on the left, which shows again that base model originally, and then you'll see these 2 additional curves. And so the purple curve is if schools were to reopen on May 17th, and the green curve is scenario 2 if the schools were to reopen on May 31st. So for all of these, the stay-at-home order would stay in place through May 31st, which is just off from what was actually announced ultimately. And then these curves display what is modeled to happen if those were to reopen. And so you'll see here in terms of the numbers of cases, the number of cases that would be expected is increased by 997 if they were to open by May 17th. And this goes through until later in the summer. This 422 is if they were to reopen on May 17th. Now, when we're talking about numbers of cases, this isn't all cases that are expected to happen in the schools. In fact, the majority of them would not be anticipated to happen in the schools. It is what happens when you increase mobility, increase the degree of contacts that happen when the schools are open again. And so that those cases would happen throughout the population, not just in the school population themselves. Similarly, here you have the forecast, the base forecast in terms of what is anticipated to happen for the number of hospital admissions, and then what would be expected to be the increase if schools were to open here in the purple on May 17th as plus 34, or on May 31st as 13 more hospitalizations compared with that base rate. Finally, we have here I just make one comment here, because as Hamilton is a center for both tertiary healthcare from receiving patients from across our region and to some extent from the north as well. And with load leveling, as it's called, which is what has been going on for the last many weeks in terms of ICU patients from areas to the east of us being sent out to other centers such as our own, and we've received a number of them in order to ensure that everybody has access to hospitalized care and ICU care. These forecasts are just for Hamiltonians, so they're not, they don't take into consideration what might be happening for other reasons like load leveling. These are just the number of cases amongst those who live in Hamilton. In terms of the number of deaths, you can see in modeling out those 3 different scenarios that the impacts from opening up the schools earlier would have a very small impact in terms of the number of deaths that might be anticipated. So with that, I'm going to turn now to just go over the performance metrics that you know are collected at provincial level and that we go through on a regular basis. Again, as Steph said earlier, these numbers are current as of Friday, except if there's a particular one that's noted as we go through. So our weekly incidence rate per 100,000 population is declining. We're now at 140 cases per 100,000 per week. And so that has been coming down slowly from that peak level. Our percent positivity is down to 8.4%. You may have noticed from some of the work that we have been doing that we had noted some challenges around our percent positivity and the way it was being calculated in terms of taking the data off the Ontario Lab Information System, or OLIS as we call it, and just what they were calling positives. And so there's been some changes to this, and we'll note that on the website as we go forward. The number's a little lower than it was reported earlier. The effective reproductive number, this has gone up and down throughout this peak. So 0.86 a couple of weeks ago, that's just a couple of weeks ago, and then up to 1.12 and now down to 0.82. So it's, although it is a good indicator, it's not one that we track as closely. Percent of community acquired cases has stayed stable throughout at about just under 30%, 28%. In terms of our public health system capacity, we have now gotten back up to 92.8% of our cases being followed up within 1 day of them having been reported. Significant level of change that is due to 2 things. We continually go through and look at ways that we can improve our throughput. What can we do in terms of case management? And so that has certainly helped that number. And of course, the decreasing number of cases has helped that number as well. The percent of newly identified close contacts that are reached within a day, that's still at the 80% range. And so still a little bit more challenging. We, of course, are doing that in combination with a number of partners at the federal and provincial level to help us with that close contact management. Here we have the health system capacity metrics, and we've got that overall acute care medicine for adults as well as surgical hospital occupancy. You'll see those numbers have come down somewhat at St. Joe's. At HHS, they're still fluctuating in terms of the number of hospitalizations. And of course, these do take into account those that have been transferred to Hamilton to both St. Joe's and HHS for load leveling purposes. And so they have been helping out as part of Team Ontario, as it said, to manage patients from across Ontario. Similarly, in the bottom statistic in terms of ICU capacity and occupancy, you'll see we're still sitting at about 88% and 80%. Again, this is both those patients from Hamilton and from our catchment area that we're supporting, as well as those from across the broader province. The ALC piece that you see here, the alternative level of care patients, these are patients who could be in long-term care or other types of care that have not been able to move forward. You'll see that these numbers have come down quite a bit. And this has been part of the good news story of moving people into care that is more appropriate for them. They have the types of supports that they need in that care. Through this period, as you know, it may not necessarily be the site that people had wanted to go to, but that ability to move to that site is, that preferred site is being maintained. They're just in a different site rather than a hospital site until they get there. I'll just note as well here on Friday, there were 2 active outbreaks at Hamilton Health Sciences, one at Juravinski and one at St. Peter's Hospital. And these are down again from what we were seeing at the peak. You know that we track additional local indicators to look at vulnerable populations, and you'll see here that our trends have been stable in these. You'll know then too, they don't tell the whole story of what is going on and what is being experienced. We know that mental health stressors, we know that the kinds of challenges that people are experiencing are broader than these indicators can represent, particularly amongst kids. But we do continue to monitor an overall level in terms of the vulnerable patients and vulnerable populations here in Hamilton. So with that, I'm going to go on and do the first half of the vaccine update, and then I'm going to turn it over to Jen Vickers-Manson, who's going to talk more specifically about some of the efforts that we've been making on this front. So you'll know that our objectives around this program continue to evolve. During the first phase of the rollout of the vaccine, the main objective was really looking at those high mortality rates that were being experienced in those that were living in long-term care and retirement homes, as well as those who were amongst the oldest age groups. And so very much looking to prevent deaths. And as you saw from Stephanie's presentation, we've had a lot of progress on that front with our death rate coming down due to the vaccinations that have happened there, as well to prevent illness, hospitalization, and intensive care unit admissions. And you've seen that while we have had continued ongoing high levels of hospitalization and intensive care unit admissions due to the high numbers of cases that we're having, there are considerable impacts still happening here. And so continuing to stabilize our healthcare system as part of this effort has been one of the objectives that we're still very much working on. Reducing transmission, of course, just overall has been another objective of this vaccine strategy. And as you've seen, the opening to broader and broader populations, both by age as well as the kinds of work that they do, has been a big part of trying to reduce transmission, as well as vaccinating those that are in hotspot areas where higher levels of transmission have been experienced. And so this dual age and hotspot place-based strategy has been part of the work to reduce that. And then overall to achieve high levels of population immunity. And so as the program continues to open up to those that are at lower risk, as you will see happening over the coming weeks, that will be to try and bring those population levels of immunity up to get us to levels of herd immunity that will make it much more difficult, no matter what part of the population you're in, for the disease to spread. So you've seen this a number of times, our placemat, as we tend to call it. And this is our overall vaccination strategy. And we're here in phase 2. And continuing to move through these different populations that, as I said, are amongst our highest risk health conditions, are amongst those who are in those high risk neighborhoods, as well as those who, from a work perspective, cannot stay at home and work, have to go out and work, are very much out there supporting all of us. And so vaccinating those individuals as well. You'll remember that in our final phase, which is really moving quite up, it still shows it here as being in July. And you'll excuse us, we haven't continued to do all the graphic work to update this at this point, but really this has shifted significantly to the left. And as you'll see in just a moment, you'll see that we'll be moving forward with vaccinating the broader population much earlier than was initially anticipated. The approaches to vaccination, the mainstay, and I quote my good colleague Jen Vickers-Manson around large-scale clinics, the mainstay of our vaccination approach in terms of immunizing the most people in the most efficient fashion is through these large-scale clinics. We know from our colleagues across healthcare that our health human resources are extremely stretched, whether we're talking about people who are working to support people through the emerge department, through the hospital wards, or in the ICUs, or we're talking about those that are supporting people through vaccination and primary care and those sorts of routes. Health human resources remains a considerable challenge. And so to get this vaccine out as quickly as we possibly can, we rely as much as possible on people coming to these large scale clinics and helping them to get to these large scale clinics, while also doing some targeted mobile and on-site clinics. And so, we've done clinics early on around different parts of the city, but more and more so focused on those that are at highest risk because of an FSA perspective or an essential worker perspective. And then, of course, we've been working with our primary care and pharmacy clinics. Those as well got moved much further forward than were initially anticipated. And so we've had both primary care pilots as well as ongoing primary care continuing to roll out, as well as pharmacy clinics, not originally where we would have liked them all to be, but in place and continuing as we went through the initial phase with AstraZeneca, now moving over to using Moderna and making sure that we can maintain the safety of that vaccine as it's used in these different clinic sites. So going well. And this, of course, will become the mainstay of how people are vaccinated in the long term. And so we've also been looking at through this particular last several weeks, looking at how we can transition to more and more so those that will be in an ongoing, sustainable way able to carry out this vaccination program through primary care, through pharmacy clinics, and through whichever other modalities are going to be necessary to complete this over the long term. Get my cursor back in the right spot. There we go. So where do we stand as of the end of day on May 13th? So the data we would have had to analyze on the 14th, you'll see that we had 232,000 doses administered thus far in Hamilton. And now you can see the number of doses that are given each day along this curve at the bottom and by which clinic type they are being administered through. And you'll see that as the vaccine supply has increased, so we had those difficult days through February and early March where Pfizer had shut down their manufacturing in order to boost up their manufacturing capacity. And then you'll see that supply increased through March to some extent, and then much more so beginning the end of March and through April. And again, we're seeing an increase again that is just starting here now where we have had I think now 2 or more 4,000 plus days of vaccination through all the various modalities that are going on. You'll see here that Pfizer by far is the main vaccine that we have available and are working with, while the Moderna also plays a role here. We're using that very much in our pop-up clinics, in our smaller clinics, because the supply is a little bit more spread out over time, and whereas the Pfizer comes in weekly quite reliably and is used in those large-scale clinics to push through those numbers of vaccinations. The AstraZeneca front, this has been the routes that have been done by our primary care partners as well as by the pharmacies. And of course, now that piece of the vaccination program has been paused. And I'll come back to that in just one moment. Oops. For some reason, I keep skipping, going 2 slides forward. So what you see here is our percent of our population, our adult population 18 plus, who has initiated or completed a vaccine series with at least 1 dose, and we're sitting at 45%. We're lower than the provincial average because, as I said, 50% of the vaccine for the last couple of weeks has been concentrated in the hotspots that are by and large focused in Peel, Toronto, and York. And so while we are having some benefit from that, we don't at all have this amount of vaccine that those locations do, but we are continuing to catch up. Down here at the bottom shows you a table of how fast it took us to get from 0 to 10% of our adult population vaccinated, and that took us 88 days to get from the beginning of December through till March when we got to that milestone. To get from 10 to 20 took us 16 days, 20 to 30, another 16 days, 30 to 40 was 15, and we anticipate that time to continue to decrease as we go forward. From an age group perspective, you'll see here our percent coverage with at least 1 dose of vaccine across the age groups. As you'd expect, the highest rates of coverage are in that 85 plus group, where the focus was initially, with then decreasing amounts. We've been working through these age groups in the latter half over the last couple of weeks with them being able to book and now having their actual appointments in the clinics to see those rates come up. And then of course, these are the age groups who will have been eligible through different routes as essential workers earlier on. You'll see at the bottom here, we use the 15 to 39 age group. The bottom level, you may say, but it's now been improved down to age 12. Why don't you have that? And that's just a data challenge that we have in terms of our source of data to give you, we can't get it broken down right to that age 12. So we'll work on that and see what we can do. But amongst those in that age band, we're sitting at about 17% overall, with again, the higher numbers being in those that are amongst the older age groups there. This gives you an idea of where we sit with vaccine coverage across the city. In this graph, just to draw your attention to it, this uses all ages. So it's not just 18 plus. In this one, it is all ages. And so you'll see here, there's a new average to look at across the bottom of the slides, showing that when we look at it this way, we sit at about 34% of our population has been vaccinated. And you can see some areas have higher coverage rates. Amongst those are one of our hotspots, L9C, has done very well. They have a MassVax clinic there, as well as other pharmacies. Of course, we're focused there in the early days of the pharmacy rollout and continue to be focused there with the Moderna rollout. L8W is another provincial hotspot sitting at about that average level. L9K is one of our locally determined hotspots. That's done very well and sitting at about 44.9%. Two of our other hotspots, L8L and L8N, they are sitting below the average still, but these two have had some of the highest gains in vaccination coverage over the last many days. So you'll see here that we do have other areas that we are going to continue to work with around how can they improve their access to vaccination, what are the supports, and as the vaccine ambassadors, you'll know that we've been doing this work in part with the Vaccine Readiness Network, which Jen's going to speak to in a minute, but as well with our vaccine ambassadors, what more can we do in terms of continuing to make vaccine accessible to, information accessible to those in those other areas. Overall, what you'll see as we go forward, you'll recognize this chart as one that the province put out now several weeks ago and gave the expected rollout of the remainder of the vaccine program. It is updated this week as we've added that 12 to 17-year-old age group, and you'll have heard announced today that while we were anticipating to drop to 30 and older, we're now hearing that that's going to get moved up sooner in terms of this coming week and moving through that 18 and older age group earlier. I know as well, we're all thinking about the upcoming long weekend. We will, of course, be continuing to provide clinics through the long weekend. We know over the previous long weekend, the previous holiday weekend, there were some challenges in terms of filling vaccine appointments. And so Hamilton Health Sciences opened up their clinic on Wellington Street to walk-ins over that weekend. I'm not saying that that's exactly what's planned to come, but we're very mindful of that coming up, that sometimes these weekends don't seem to be those that people are able to come out to. We do have good booking rates throughout our main clinics through that weekend, but we'll continue to look at are there additional ways to make sure we support getting out every day as much vaccine as we possibly can to those who need it. Those hotspot age bands, of course, have been down to 18 and older now since the week of May 3rd. You may say, why is it not 12 plus? And we've been working this through with the province. The concern is that, of course, the Pfizer vaccine can be used for those that are 12 to 17. The Moderna vaccine cannot be. And so making sure that there's access to Pfizer for everyone is something that we're all working on together. You'll see as well here the highest risk health conditions first became eligible April 26th, those that were in the high risk the week of May 3rd, and last week the at-risk health conditions. That's all through self-attestation. So people just need to go on the clinic appointment system and attest that they belong to those groups, and they would then move forward. Now, once we drop to the 18 and over very soon, that will of course become a moot point. It will, though, for second doses continue to be something as a small number of those who are in these highest risk health conditions and highest health conditions are permitted to have a shorter second dose interval. And so we will continue to work that through with those individuals. And then, of course, the group we've been talking about, the group who cannot work from home. Initially, the teachers, licensed childcare workers were prioritized, and then the group 1 and group 2 groups. And so you'll see we are moving through those. And again, they became eligible those weeks and will be having their appointments as we speak over these weeks. So supply has really changed from what we talked about a couple of months ago. So by the end of May, everyone who is 12 and over who wants a vaccine will be able to book an appointment. But there will continue to be a lot of support that's required in order to make sure that people are able to access vaccine. And as well building vaccine confidence. And you have heard about some of the challenges that we've had. A lot of people do have questions about what the vaccine means for them or about chronic conditions that they may experience and how is it something wise for them? And so having these conversations with trusted leaders in your community, having these discussions with your healthcare providers, if it's a matter of healthcare, are a critical part of us getting vaccine to everybody who wants to have it. So we've talked about the 12 to 17-year-old opening up. We are working with the school boards to look at vaccination of 12 to 17-year-olds. We will have a plan in place as due by the 20th of May, by Thursday of this week. The ideal timeline is going to be for that first dose to happen during the month of June. And as you've seen in provincial announcements, we're looking at family-friendly clinics within the mass vaccination sites to be set up the week of June 14th and the week of June 21st in order to support families in being vaccinated. There are changes being made to the provincial system to support that as well. And of course, we're going to make sure that Pfizer is available in those clinics for everybody to come and be vaccinated. The timeline for the second dose is meant to be the last, or the middle 2 weeks, I should say, of August, so that they're completed by August 22nd. And so we'll be working again with the school boards as part of this planning to look at how we can make that happen in August. AstraZeneca, just a quick note about AstraZeneca. I know it's caused a lot of discussion and confusion really over the many months that AstraZeneca has been available. On May 11th, you'll know that the Ministry of Health did pause first doses of AstraZeneca out of an abundance of precaution because of an observed increase in the rare blood clotting condition that is known as vaccine-induced immune thrombotic thrombocytopenia, or VITT, in individuals after they had received the first dose of AstraZeneca. They are going to be making a decision, hopefully within the next couple of weeks, about the second dose approach for those who have received a first dose. Second doses will begin to become due for people in the month of June. And so that is why the province is taking the time to go through the information from the UK and the experience they've had there, where they've had a very successful vaccination program using largely AstraZeneca and looking at issues such as incidence of these complications after second doses, which appear to be very low, much lower than after first doses, and as well looking at the potential for combining different vaccines, having a different vaccine for a second dose. So we expect those decisions to come soon. Those are, of course, not ones we can make at a local level. We really do rely on the federal government and the provincial government in terms of their expertise and the healthcare partners that are supporting all of those decisions, and in fact, really globally, as we work with other countries who have had more experience than we have had with these vaccines. And with that, I'm going to turn it over to you, Jen, if you're ready to pick up. As you all know, Jen Vickers-Manson, she is our Director of Healthy Families and our Planning Chief for the response. So Jen, over to you.
Thank you, Dr. Richardson, and good morning, everybody. I'm going to be providing a brief update about our Vaccine Readiness Network. So this is a network that has been meeting since the end of 2020. It's a local engagement group for the COVID-19 vaccine. The group has been assembled in order to engage with various stakeholders across the city. And the purpose of engaging stakeholders is to describe and share provincial direction related to vaccine prioritization, to enhance local awareness related to vaccination, both type, frequency, and timing, to understand barriers that racialized, marginalized populations face, and to identify information and access needs and opportunities. And then to engage the community in creating meaningful resources and champions for key populations in our community. Just want to give the Board of Health a sense of who is at the table and who we are engaging with. It is a very large group at the Vaccine Readiness Network, and we have our local family health teams there. We have community health center representation. We have our hospital partners. We have home and community care, our Children's Aid Society. We have social housing and shelter groups. Our university and colleges are represented as well. Our school board partners are at the table. We also have our Hamilton Health Team leadership, mental health servicing agencies. We have the good fortune of having a regional ethicist at the table with us as well. And then in addition to that, we have the Hamilton Roundtable for Poverty Reduction, Hamilton Centre for Civic Inclusion, Disability Justice Network of Ontario, our long-term care homes and retirement homes, our Indigenous servicing agency, as well as some other vulnerable groups. So it is a rather large table. And as a result of that, we often break off into smaller planning groups relative to specific functions that we're trying to achieve. Just do want to set the context and remind our Board of Health that we also have the Hamilton COVID response table. You'll recall that this has been in place since the beginning of COVID-19, and this table has representations from healthcare organizations and social service agencies across the spectrum. And the purpose of that group, which is chaired by Dr. Elizabeth Richardson, the president of St. Joe's Hospital, Melissa Farrell, and Dr. Scott Woodard from Primary Care, is to ensure that we have a consistent and coordinated and collaborative approach to dealing with COVID-19 in our community. So just want to acknowledge that there are many engagement tables occurring at different levels and situate the Vaccine Readiness Network within that. The purpose, of course, is with these tables, as with many population health issues that are far-reaching, like the pandemic is, a collective impact approach is required in order to make a difference in our community. And that is what we know is that those who have trusted relationships with key communities in our city are really important to leverage in terms of amplifying the message and working with the communities that they service. Next slide, please. So just to provide a bit of a sense of what the feedback has resulted in from this table, the key contributions. So there really has been some great feedback and suggestions for our targeted mobile pop-up clinics for those disproportionately impacted by COVID-19. So of course, you'll be well versed in our hotspot clinics as well as the Black and racialized people of color clinics. You'll know that we're running currently at Restoration House, and this week we will be at the mosque on York Street as well. You'll know that we have the Perkins Center for our Indigenous community. We've popped up for our shelter staff and residents. Temporary farm workers we spoke to at the beginning of the meeting. As well, we've done mobile clinics for our disability services, and we continue with our homebound pop-up clinics. Just a reminder, our mobile pop-up clinics, and we've talked a bit about this already today, is really always a balance between speed, self-determination, enhancing access and equity, and feasibility from a resourcing perspective. And so what I mean when I say that is that we do know the fastest lane is our mass vax clinics. They are well established. They're set up to service a lot of people at a rapid pace, and we have found a lot of efficiencies in running those clinics with our partners. The self-determination piece is that we do have targeted outreach options for some of our community members, and that they also do have the option to book into any clinic as soon as they become eligible. And then, of course, there is a piece around enhancing access and equity, which is absolutely needed and required. And I think some of the key examples of this is our Restoration House, our mosque, our Perkins Center, as an example. We do recognize these pop-up clinics tend to be a bit of a slower lane. They take longer to set up. We have to do some inspections, etc. We can't push through as many people through those sites at quite the same speed, but they are offered in community at sites that are more recognizable to some populations and can increase comfort and access for those populations. So it really is always about finding that balance. In addition to the targeted mobile pop-up clinics, we also have had significant support from our community partners with supporting outreach and booking. And this has been really key to our success. You can imagine that our community partners who work with these populations and service them on a regular basis, pre-pandemic and during the pandemic, have well-established trusted relationships, and these are the types of relationships that really contribute to enhancing booking in our community. Next slide, please. Here's some key examples. We do have a vaccine confidence group, and they have been working, it's a small and mighty group. They have been working to engage with subsets of our vaccine readiness network and really been reaching out to have some more in-depth conversations to understand what the vaccine confidence needs are, hear clinic location ideas, and discuss outreach opportunities and channels. As a result of these conversations, and we've had many, there's been about 52 engagement sessions to date with, and I'll just give you some examples. So we have our Seeds of Leadership, which is our Muslim and Arabic community, as well as our Black Health Leaders Forum, our Black African Francophone Leaders, the Nigerian Canadian Association, the Afro-Caribbean Canadian Association, our Immigrant Women's Center, our good partners at Wesley and the Y, HIPC, as well as our Indigenous partners. We do have also been engaging with our ESL programs and immigrant and newcomer groups. So just to give you a sense of the kind of one-to-one meetings that we've had in order to tailor messages, print, videos, and social media resources for communities with high vaccine hesitancy rates. We have done live vaccine Q&A sessions for priority populations. The one example that stands out that we've done really recently, maybe I'll just talk about two, is the one that we did with our Black African Francophone leaders. It was a Q&A session with Dr. Doug Sider, as well as a community leader that was translated and was live. In addition to that, so those are live, and we do have some pre-recorded as well that folks can access. And we are just in the process of working with our primary care partners to develop a speakers bureau so that we can have these types of events where our community has access to experts and are able to get questions answered that are meaningful to them. In addition to that, we have our hotspot forward sortation areas, clinics, as well as the mailouts that have occurred in these areas that have been translated. We do have translated resources. And so you'll know that we have vaccine fact sheets translated in 31 numbers and languages available on the website. In addition to that, the working with this group has been really key to understand specific barriers to vaccination and to help us facilitate access to vaccines, vaccine clinics, where they're located in terms of neighborhood, the clinic, ensuring they're comfortable for the community, providing answers to questions, and transportations to clinics as some key examples. Next slide, please. This is really just a very small snapshot, both from what we've learned, what works, as well as from what we're reviewing and the evidence around what works in terms of addressing hesitancy and working with our community partners to reach out to those disproportionately impacted by COVID-19. And so what you can see and I'm sure will come of no surprise, is what works is partnership with community organizations, leadership from trusted community members, leveraging our key social influencers in the community, while also acknowledging racial inequities in the identification of priority populations. Key influencers in our community, of course, continue to be healthcare providers and reaching out to the clients that they service, vaccine accessibility in terms of the hours of clinic, transportation to the clinics, and clinics being at a familiar site for some individuals as well. And then, of course, we've spoken about ambassadors with community expertise. I will reiterate what Director Baer talked about in terms of one of the key challenges, and certainly we've talked about this at the Board of Health in the past, is that COVID-19 pandemic continues to highlight long-standing disparities that are rooted in the social determinants of health. And of course, that does continue to be a challenge, and we are trying through these efforts to address some of those disparities to equalize access. Next slide, please. So now I have the unique pleasure of speaking about the vaccine ambassadors. And so these came about in conversation at our Vaccine Readiness Network, and in particular speaking with our Black Health Leaders Committee. And we are in the process of just finishing up hiring and recruiting 10 ambassadors for the City of Hamilton. We started 5 last week, so 3 started on Monday, 2 started on Thursday, and 4 more have started today. So as you've heard, they are already out in the field. We are just trying to catch up on their onboarding and orientation to get them feeling comfortable and confident. They are very keen, and they are an excellent resource, and we're excited to really launch this program and turn up the volume on this in the coming weeks. So the 3 factors that were considered to identify priority populations, of course, were the percentages of certain populations within Hamilton, the percentages of COVID-19 cases, and the rates of vaccine hesitancy. Just a reminder that our 10 vaccine ambassadors have been hired and that they're all from Black, racialized, and Indigenous communities within Hamilton. They are here to support us, again, in amplifying the message and to supplement existing activities to address vaccine hesitancy. This again goes back to the key message that not one organization or group of individuals can do this on our own. It really is a collective impact approach that needs to be taken in order to make a difference across our community. Next slide, please. So, of course, the purpose of the vaccine ambassadors is to work with communities to build vaccine confidence in terms of answering questions that are important to them in a culturally sensitive and relevant way. Act as trusted local resources to their community. So we have heard loud and clear the importance of individuals with vaccine information looking similar to the populations that they are trying to reach out to increase confidence and enhance trust. As well, they're really going to be key in engaging priority populations through community outreach, listening to the needs of the community, and distributing information and resources about vaccines in languages that are relevant to the population that they're reaching out to. I think you heard a key example from Michelle this weekend in terms of the ambassadors attending Rebecca Street, and that was a really great negotiation with the tenant association of that building in terms of determining what they were doing, what needed to be enhanced, and what the unique role the ambassadors could play. That's a great example of leveraging both resources in the community while amplifying that with the ambassadors and working together to make a difference in our community. Next slide, please. So I'll just shift gears a little bit here. This is Our Shot is a national campaign that has some roots in the city of Hamilton. Our vaccine task force here in the city of Hamilton endorsed this campaign last week, and we will be rolling it out this week. And so Dr. Desh Seddev is an emergency doctor, physician at Hamilton Health Sciences, and came to present to us at the Vaccine Task Force to talk about that This Is Our Shot campaign. And I'll tell you a little bit about that at the next slide. This is really our communications folks that are leading this in collaboration with those who've initiated this national campaign. The goals and objectives of the campaign are to increase vaccine confidence, to decrease vaccine hesitancy, and to increase vaccine uptake. The beginning of this campaign is the union of multiple grassroots organizations that were previously culturally focused. So, for example, Canada's South Asian COVID-19 Task Force was one of the grassroots organizations that's been key in leading This Is Our Shot campaign and really started to launch it in Peel, and it has gone a bit more broadly than that. Next slide, please. So how we're going to do that locally, you'll see the campaign slogan that I showed on 2 slides ago. You'll see that staff will have T-shirts on all of our mass clinics as well as our mobile clinics. Those T-shirts will be in various different languages. There are 27 languages that they can be translated to, and there will be spots for selfies at our vaccine clinics, both our mass and mobile clinics, so that individuals can share vaccine selfies or video on social media. They can challenge friends and family to book a vaccine when it's their turn. They can share why they got their vaccine. And so by tapping into this vaccine, we're going to be utilizing both local and national influencers. So just a few examples of some national influencers that are attached to this campaign. We have Haley Wickenheiser, Ryan Reynolds, and Chris Hatfield, as well as others. We are going to utilize This Is Our Shot brand to push internal messaging on social media as well. And we will engage with ethnic communities to share clinic information and presentation through established This Is Our Shot channels. And that bullet there is language that we've lifted and borrowed from those who've launched this campaign, because they have unique channels and routes for communicating across various racialized groups. The information is in 30 different languages. And so what we know is that both here we've been hearing from our community partners, and more broadly is one of the key influencers is role models and seeing others being vaccinated. So just this last week at our Vaccine Readiness Network, we did some breakout sessions with our community servicing agency to say what's working well in terms of addressing hesitancy, what are some of the key challenges. And we certainly heard that with role modeling getting vaccines, they really start to see a change in terms of uptake. It's a very positive way to influence that. Next slide, please. And that's it for us today.
Mr. Mayor, we'll turn it back over to you, and of course, be taking any questions.
Thank you.
And I will take this down.
I forgot to wear This Is My Shot T-shirt today. I didn't know you were going to be highlighting that as a next step, which is great. Madam Chair, earlier on, or council members, earlier on, I'd asked if I could speak first on this topic, so I'm going to turn the chair over to Councillor Wilson. Thank you. And, let me just say, in terms of presentation and the fullness of it, I had a number of questions here, and you answered them all, which actually speaks to I think the very wise decision on behalf of council that presentations go first. Delegates can go after, because I'm sure many of the questions that might come up will already have been answered. And you touched on experts that you're consulting with on a regular basis, and I mean experts, folks that know and understand vaccination and the ethics of how you vaccinate, and epidemiologists, et cetera. You've got a vast team of people that are working on this, and you talked about the vaccine task force and readiness network. Again, a fulsome group of community engaged practitioners, whether it's in social services or in schools or in healthcare. Just a vast and full group of individuals that are working to provide guidance to the provincial protocols. And I'll remind everyone again that we are directed in a large sense from the provincial protocols that are laid out in terms of who gets what when. The delivery obviously is left with the City of Hamilton. And then lastly, what have we learned from other jurisdictions? So that now specific to Rebecca Street and the 3 buildings, and I know that other jurisdictions have experienced some of this in the past as well, and certainly lots of consternation around how we're doing it and what we're doing. And I know that response has been pretty fulsome, and there's been opportunities for individuals in the buildings to get vaccinated at our mass vaccination sites. And I anticipate that if there were other buildings in the community, which are residences like single family homes or neighborhood homes or high density areas in Lower City, that we would respond in similar ways. So what have we learned from other jurisdictions that may have had those kinds of issues raised? And one of the issues that has come up is it's kind of air quality within the building. And I know that Dr. Richardson, you've had someone have a look at that as well, which I think is an important issue, because that's certainly going to lead to a number of other buildings in our city that may or may not go into outbreak. And I hope that doesn't happen. I hope they're all physically distancing and masking and taking the appropriate measures, as we all should be doing. But what have we learned from that might be applicable here? So 2 issues. What have we learned from other jurisdictions that are dealing with these? They're not congregate settings. These are apartment buildings that might run into an outbreak as defined by your definition of it. And then secondly, what would we do in other locations throughout the city in a similar way?
Thanks very much, Mr. Mayor. And if through you, Deputy Mayor, if I can, I will begin to lead off on this one, and then I'll turn to Michelle and Jordan to add pieces in as they see fit, because the consultation's been done by a number of different people on the team. So as we do across Ontario, we do consult with our colleagues who've had similar experiences. So London, Peel, North Bay, spoken with our public health colleagues there in terms of what their experiences have been in apartment buildings, what the epidemiology looked like in those cases, what it looks like in ours. We also, of course, consult with Public Health Ontario, who have a number of experts that are guiding us all the way through the pandemic response, but including on this particular subject matter. And of course, we consulted with them previously when we were dealing with the Spinco outbreak, where again, ventilation had been raised as an issue. And we also have consulted with Jeffrey Siegel at University of Toronto, who's another academic expert in this area. And perhaps I'll give a bit of a summary piece about that piece, but and then ask Michelle and Jordan to speak in more detail. But when it came to those issues, we were very much encouraged to look at the epidemiology of the outbreaks that are happening in those buildings. So this is the person, place, and time the cases that do occur. Look at the patterns. Look at what the factors might be that are related to transmission, and look if there and see if there were issues that could be identified. And indeed, we could identify, the factors that Michelle spent a good amount of time describing for you in terms of the outbreak issues in those settings. And we also talked about how ventilation may play a role, what we were seeing, and we're told again, follow the epidemiology, follow the control measures that then would relate to that epidemiology in terms of what is being seen in terms of spread. And we were not seeing a pattern that was suggestive of ventilation early on, or when we looked at it again as the number of cases increased, asking those questions again. And again, consulting at that point with Public Health Ontario and Dr. Siegel, and moving forward with control measures, asking nonetheless in each of these cases, as we've been talking about since the beginning of the pandemic, the importance of ventilation, the importance of ensuring that ventilation systems are optimized and suitable for the type of setting that they're dealing with. And of course, we're not engineers, we don't have that expertise. We consult with people who are, and then ask the people who are having the outbreaks to make sure they are consulting with experts as well to make sure that systems are optimized. So that was the case in SpinCo. Has been the case when it comes to residential retirement homes, long-term care, whatever it may be, and continue to be the case with these outbreaks. But I'll turn it to Michelle and to Jordan at that point around that piece.
Thank you.
Thanks, Dr. Richardson. And I'm going to let Jordan speak to the ventilation piece, as it was Jordan who consulted with the external expertise. With respect to transmission in the building, so when looking at the EPI, as noted previously, I'll just remind you that what we found is approximately 2/3 of our cases within these outbreaks, all three of them, anywhere between 63 and 68% of cases are acquiring the infection through close contact household acquisition. So this is no different than what might happen in other households. The piece that's different is that some of these units can be quite small. The other piece, of course, is people are supporting each other in a way really that's positive and what we want to see in a community. People are helping out with childcare. People are helping out with elder care. People are dropping off food items, that kind of thing, when someone is sick. So there's lots of community support happening among the residents at the buildings. At the same time, though, there is transmission from unit to unit as a result of that in some cases. The other piece that's at play in these buildings, of course, is we have lots of essential workers here, and they are working in those types of locations where outbreaks are occurring. And these are individuals who, being essential workers, don't have the opportunity right now to work from home. They still need to take part in childcare, that kind of thing. So when COVID gets into a household, it does spread fairly easily from client to client, resident to resident within those homes. And so that's kind of what's playing out on the EPI side of things. It's all good supportive behaviors that we want to see in a community where people are taking care of each other, taking care of their family members, what have you, but very challenged with respect to minimizing transmission as a result. And then on the ventilation side, I will turn it to Jordan just to give you a summary of his findings and consultations.
Thank you.
Yes.
For us non-experts, maybe we could use long forms of words. And I know what epi means, but I think people listening in might not know. So epidemiology, I assume, is what you're saying.
Thank you, Mr. Mayor. Yes, epidemiology.
Thank you.
Yeah, so just to elaborate a little bit on some of the consultations that we had with Public Health Ontario and with Dr. Siegel with the University of Toronto, who's a professor there in the Department of Civil and Mineral Engineering. The airflow piece is certainly something that comes up whenever you look at outbreaks in buildings. One of the biggest takeaways from the discussions which, as you've heard both Dr. Richardson and Director Baird mention, is really needing to look at the epidemiology and what picture is it that's telling you. Each building is going to be unique. It can be very challenging to investigate these. You need, of course, both the building science and airflow, as well as the infectious disease piece. And airflow itself doesn't always necessarily mean pathogen flow and transmission. Compared to other things like that close contact that you've already heard Director Baird describe, it is relatively low risk, does need certain things to occur at once, and it can be hard to separate this out from other transmission factors such as contact in elevators, corridors, etc. So really being able to nail this down makes it quite difficult to identify specifically that airflow is what's causing transmission. And that's why it's really important to look at that epidemiology and what it is that you're seeing. Are you seeing, for instance, cases that are vertically stacked in a particular area where you might be worried about, or looking at those vertical chases where you have plumbing that connects multiple units? How well is that sealed off from those units? And certainly those are recommendations that we've made with each of these outbreaks in terms of looking at their HVAC systems to ensure they're optimized, to ensure they're working appropriately, looking at any of those vertical chases and making sure that they are sealed off, that they're not accessible into those units. And then, really just looking at, they mentioned as well some of the sort of the corridor pressure systems, which is very common, I guess, in building stock of this certain age, where you have what would be airflow it's being pushed into the corridors and then can be pushed from the corridors then into the units. And certainly that can create airflow, but airflow again doesn't necessarily mean that you've got pathogens being transmitted. And that's why it is so critical then to go back and look at that epidemiology, look at the distribution of cases in the building, look at the connections that you've been able to identify through case management, and what really does that tell you. And that's how we've been looking at these particular buildings.
That's great, thank you. And so it leads me to, and I'll end on this question and ask to go back on. I don't want to monopolize the time. We have a number of social buildings, social residences throughout the city, high rise or multiplex facilities. And in terms of outbreaks in any other location, would we be approaching that in the same way as we've approached this one in terms of ambassadors out there? I think my sense of it is that in many of these social housing settings, marginalized individuals or otherwise, we see significant hesitancy in terms of vaccination. And so preventing outbreak and encouraging, vaccine uptake seems to me to be more pronounced in our social housing areas throughout the community. So Dr. Richardson, is there again kind of a secondary strategy to look at areas where we might see less physical separation happening, less more supports happening, as you've indicated earlier, in terms of healthcare or childcare in those settings, and how are we going to address the vaccine hesitancy that we're seeing? And you did speak to some of that, but I think it's worth reiterating. And then, Madam Chair, if you'll put me back on for a second time.
Through the Deputy Mayor. As we've gone through this experience in the pandemic as a whole, and in these particular outbreaks in particular, as you've heard, the social determinants of health have been highlighted by this, and very much a lot of the work that we've done has been shaped by an understanding of the social determinants, what they mean, how they play out, how they're impacting people. However, our approach to this pandemic isn't going to fix the social determinants of health or address, create the policy change. There's been a lot of discussion, for example, about paid sick leave, and there's been advocacy from this Board of Health about the need for paid sick leave so that people can go off when they're not well and or need to go off because they're under quarantine. There's been advocacy on a number of factors about a number of issues related to long-term care and what we have seen in those situations. So we'll continue to do what we can to mitigate the impacts of that, to educate, to support individuals, but by no means will we be able to fix the challenges that are ongoing and need a broader societal discussion and policy change. So as we go forward, in these circumstances, we'll continue to look at from again that epidemiologic, which really just means person, place, and time perspective, and looking for what happens across those different dimensions. We'll look to see if these increased case rates are happening. In this instance, we were looking at them from the standpoint of a particular building, but they're happening that's a vertical sort of collection, but they happen on the horizontal level across addresses. That's why we see these hotspot FSAs, as we call them, or particular areas of the city. That's why we see them happen, and why we see a lot of transmission. A lot of it, again, comes back to social determinants of health, essential workers who are continuing to go out to work, needing to find support, having those connections through childcare, through other things, those are all good factors from a community cohesion standpoint, but they're part of also what is driving some of the spread that is going on. So we'll continue to look for those circumstances where we see that we have more transmission than one might expect happening in a particular area. We will go in, make sure that there is nothing different that is happening in that particular site. Look at how we can help people to understand what it is that might be contributing to it. Are there circumstances that need to be looked into further? Are there more supports that are needed? You'll know that with every case that we manage, we offer them social supports, as well as our providing them with the case management information, the disease control information that they need to have. We also talk to them about, what do you need in order to to be able to serve through an isolation period or quarantine period, or are there other factors that are a challenge for you, and what help might you need? And our colleagues within both our own Healthy and Safe Communities Department, but also across the city, help to support people who are in that circumstance. So we'll continue to do that work at an individual level. We'll continue to look at where testing might be indicated, to look at how many people otherwise might be infected. And of course, any place where we look, we will see higher rates. We know that generally in the city, probably in the science that's been done, somewhere around 10-20% of people actually get tested. So where we offer testing and bring it to people that may not have realized they were infected or not been able to get to testing, we will see those higher rates. We will also go in with, from a vaccine perspective, working with the Vaccine Readiness group and the vaccine ambassadors to talk about, how can they get access to vaccine? What have they already done? What have they signed up for? We certainly found this in this case. We did have some that were already vaccinated, some that have been scheduled to be vaccinated because they are essential workers, and looking at how we can help decrease any barriers to vaccination. In this case, we found a number of people did have questions around their particular circumstances from a health perspective and how did it fit. And so, of course, we can give some advice, but really usually people need to then talk to their own provider about their own specific circumstances. And then provide transportation to vaccines, and where people truly aren't able to leave their home or have those sorts of barriers, then the homebound team does come in and support as well. So we'll continue to offer those measures as we go forward. Michelle, did you want to add anything?
No, I'm good there. Thank you.
That's great. Thank you. I'll get out for a second time, but thank you for that. Thank you for your great work. I appreciate it. I'll take the chair back, Madam Vice Chair, and turn to Councillor Jackson.
Thanks, Mr. Mayor. And just to start off with Dr. Richardson and epidemiologist Hughes, directors Bairds and Vickersmans, and outstanding presentation, so educational, so informative. I yearn for the pre-COVID days, Mr. Mayor, when I would have this team at traditional town hall meetings in Ward 6. I know it would be, your PowerPoints would be so well received. It would probably be standing room only crowds from the East Mountain community that is very active and very interested as well. So well done today. 3 quick questions for you, Dr. Richardson, please. I think I sent this out to you last week, and I said if you could for today's meeting. I listened so carefully to the entire presentation, and the 3 questions I'm asking, I don't believe were addressed. Firstly, Dr. Richardson, for the pause on the AZ vaccine, I've had a number of families late last week concerned. They got the AZ. They didn't know if there was any downside to them now suddenly shifting to a Moderna or a Pfizer. Was there any downside whatsoever to do that in light of the fact they had an AZ vaccine the first time? Through you, Mr. Mayor, please.
Yep.
Through you, Mr. Mayor. Thanks, Councillor Jackson. So in terms of the AZ piece, you're right, it's not written out in detail on the slide, but when it comes to AZ, the vaccine, in terms of what's going to happen next for their second dose of vaccine, that's being worked out. That has not been determined yet. And so our provincial colleagues, our federal colleagues are looking at the science along with experts from across the country. And they are looking at the science from other countries as well, from the UK and elsewhere. And so they will be making recommendations. We know that second doses don't begin to be due until into June. And so we have a little bit of time to make that decision and use the best possible real world evidence as it is collected. And so that's expected to come over the coming weeks.
Thanks, Dr. Richardson. Second question. You know, Dr. Richardson, I have not stood in the way of the specialized attention for the BIPOC population in our community, the Black, Indigenous, people of color, racialized. I have not stood in the way of the specialized clinic. And I heard much reference to it by you, Director Vickersmans, and today continuing to roll out the vaccine. Absolute support. However, I did not hear, as I heard 3 weekends ago, which I was so relieved and pleased to, on behalf of non-BIPOC families in the 5 hot zones designated, including the one in my Ward 6, L8W, I want just reassurance today that the non-BIPOC families are as well 18 plus eligible for the vaccine equally at this time as the BIPOC clinics are providing. Through you, Mr. Mayor, please.
Through you, Mr. Mayor. There do indeed continue to be multiple groups and multiple routes in terms of getting vaccine and prioritization. The FSA groups that are 18 plus are eligible to go to special clinics in terms of those who are FSA based, and very soon when they drop to 18 plus overall in the community, they'll be eligible to go to any they could register for any vaccination clinic across the city. So yes, they are there as well. That's for the ones that are provided through public health and the healthcare partners, St. Joe's and HHS, as well as our primary care providers, as well, of course, that we have the pharmacy clinics that were stood up using Moderna as a next stage in implementing that route. And those have been stood up right now in L9C and L8W. And then we anticipate that they're going to be increased across the community as experience with this route of taking these more fragile vaccines and success with them grows.
Thank you, Dr. Richardson, for that reassurance beyond a shadow of a doubt. Third question, Mr. Mayor, for Dr. Richardson, and then if I have time, and if General Manager Johnson is with us, I have one for him. Last question for you, Dr. Richardson. Word on the street is growing stronger that the province may rescind the stay-at-home order sooner than later to the June 2nd date they had announced. I had word on the street is that there may even be a vote in the House today in the legislature brought by one of the other parties. We'll see where that goes. My question to you is that if the province rescinds the stay-at-home order and allows for outdoor activity, i.e. golf courses, tennis courts, basketball courts primarily, will we comply with that? Will it be your recommendation to support that? And if you're scratching your head wondering, Dr. Richardson, why I'm asking that, if you recall, local authorities here in Hamilton, EOC, the MOH, a week before Christmas recommended we go in gray lockdown a week before Halton Niagara, and in March was recommended we go into gray lockdown again a week before Halton Niagara. So my question to you, if the province rescinds stay at home for outdoor activities, will we comply and support that? Through you, Mr. Mayor, please.
Through you, Mr. Mayor. So we will continue to work with the province in terms of what they advise as we go forward. And you're right, we don't have anything specific in terms of the announcements. What we, are hearing is that there's going to be a gradual opening up in terms of what goes forward. And of course, we're continuing to advocate that kids go first, that when we look at this, there has to be adaptation that relates to children and their impacts, and we need them to receive the benefits of opening up first. And so expect those to be shaped in that way. But there aren't any specific things that we are planning that I'm planning at this point from a public health perspective. And I'll turn to Paul to just answer further from a broader city perspective.
Thank you, Dr. Richardson. Mr. Mayor, would you allow me that to General Manager Johnson, please?
He's here already. Go ahead, Paul.
Great. So through the mayor, we will continue to wait until the stay-at-home order is lifted. At that time, be looking at all of the pieces that we can move forward on. I would say our goal is to be as aggressive as possible to open as many things as is allowed, either by the provincial guidelines or by our local guidelines. And that's one of the reasons that we are preparing for a very large scale amount of activities in our community towards the summer. We will scale those back as we need to because of the orders that we receive either locally or provincially. But our goal is to make this summer far more participatory from a city facilities perspective and a program perspective than it was last summer.
General Manager Johnson, thank you. That was the essence of my question specifically to you. You've replied, fingers crossed. Paul, I would simply ask supplementary last one, Mr. Mayor, please, between yourself, Parks Department, Rec Department, Facilities Department, please in these next few days, if maintenance needs to be done on a tennis court, getting it resurfaced, please, I would implore, do it now while they're closed versus the day comes the stay at home is rescinded and then we're still keeping them shut. Oh, geez, Councillor, I forgot to resurface the Huntington Park tennis courts. Through you, Mr. Mayor, and that's my last question.
So through the mayor, absolutely. Our goal would be, to do all of this now and be ready, barring any emergency break that's happened in any facility. But yes, we don't want to wait a single moment. And I've really asked our folks to look at what it will take to make sure that all those amenities are open and even what safety precautions we'll need to put in place so that the maximum number of people can enjoy those facilities. That is our goal. And the minute we're able to do that, we'll be ready. So we're already starting those conversations from an EOC perspective so that there is also no delay. Whatever the day is that we'll be able to do that instantaneously.
Mr. Mayor, as I've always done through these 15 months of the pandemic, I salute our leadership. Thank you, Mr. Mayor.
Thank you. Councillor Farr.
Yeah, thank you, Mr. Mayor, and I appreciate the questions from Councillor Jackson. I actually asked his last question to our Recreation Director on Friday, Chris Hurstek. So I'm convinced, and I'll through you to Paul. I saw that he's turned off, but since he's there, I was pleased to hear that we are actually already working on things like tennis courts and golf courses and other rec amenities to be ready to hit the ground running. So I was glad to hear that. But specific to Ford's comments yesterday, camps, Kadaka, our unique city SUPI program on many of our local parks. What exactly did Ford say, and how does that fit in here?
So through the mayor, there still are questions, and there's a difference obviously in the camps, the overnight camps versus the day camps. There seems to be a push, and that's very much in alignment with what we're doing here at the city, which is to get day camps ready to go and as much opportunity as is possible. There will no doubt be regulations. There will no doubt be size constraints and things like that placed on some of these activities, but our goal will be to have as many people as possible in. We've begun our registration for our summer day camps. So again, our anticipation is that we'll be in a position to offer, if not every single program that we would want to offer this summer, the vast majority of it are SUPI programs. We are planning to have a full SUPI program in place for the summer as well. And again, we will just react to what the health regulations are around them, and whether those are locally placed, whether those are provincially placed, we'll be able to respond. But our thinking, and this is a shift that's different from a summer ago. Last summer, we were very conservative in our approaches because we knew so little about this virus, and we also had no vaccine program rolling out. This summer, it's a little bit different. It's how do we push to the absolute maximums of safety, both for our staff who work in them and the children and the families who will be accessing them. So I think you'll see many more of those programs go, and everything you hear, I think people are on the same line that in the summer, these outdoor activities certainly are going to be in good shape. The day camps that do use indoor and outdoor spaces, there'll obviously have to be some precautions and restrictions around them for safety purposes, but our goal is to be there, and there certainly seems to be a push that day camps are a key part of what's going to happen this summer for children. It's a big part of that socialization as well. Who knows how much of their school year they'll have left, but let's make this a great summer for kids.
Next question for Michelle Baird, and I'm not surprised we're emphasizing in our training of our young people who are going to be running programs like Kadaka and the SUPI program that there'll be this emphasis, as Paul just noted, on safety. I'm sure the parents of these kids will be watching our summer staff closely to ensure that happens anyway. Michelle, I first want to just ask you, I'll direct you to send me your notes. You had a great series of comments and one slide today, and I would appreciate that. I know you've been very, very busy, and I just took a lot of notes. I'm not going to regurgitate them and try to reread from my own scribbles, but if you were to share what you can from what you shared publicly here in writing, for me particularly in Ward 2, I find that very helpful. I just want to quickly, Mr. Mayor, 235, Rebecca, you covered as our chair of Board of Health, Mr. Mayor, so much, and it sounds like you're going on a second time and you're going to cover more. Jennifer, with the final slides, 34 through 37 or 8, was very, very helpful in answering many of my questions with respect to particularly the header social determinants of health and how it might be related to 235, to Wellington, and to Queen. One of the things you said, though, that I scribbled that I will repeat through you, Mr. Mayor, to Michelle, is only 41 people vaccinated in that high rise at 235, Rebecca, and it seems awful low. 28 homebound visits, but you said not even half of the 28 homebound vaccines took us up on getting vaccinated. So this past weekend, they pretty much had First Ontario Centre down the road on Bay Street to themselves, and yet a very, very small percentage. So Jennifer's notes, slide 34 through 38, to me say, and if you could please confirm through the mayor, that what we're doing now with the engagement with our team, the network collective impact approach, being necessary with our vaccine readiness network, and those ambassadors going forward, will that program, the vaccine readiness network, help get that awful 41 vaccinated in a place like 235 greatly increased.
Okay. Just in the chat, there's an update on the 68 Rebecca residents were vaccinated over the 3 days. So just an
I had
update
41.
Yeah.
Somebody said 41.
So
through you, go ahead.
Go ahead, Michelle. Sorry.
Through you, Mr. Mayor, the 41 were the number that went to First Ontario Place. The councillor is correct on that. And then the others were vaccinated on site at Rebecca. So there were 28 individuals that the individuals offered vaccines. Some of them had other issues and some concerns. We were able to find folks on site though, so additional people received vaccine. To your question about how do we increase vaccination and what do we do in situations like this going forward, I think there's a couple things. First, you know, the decision to receive a vaccine is an individual decision. As we spoke about early, individuals, you know, people need different things to support them in making that decision, whether it's overcoming barriers like transportation, whatnot, that we were working to do. But in many cases, they're looking to talk to, be it a trusted leader, their healthcare provider, some individuals, of course, that have underlying health conditions. In a moment, it's difficult to make that decision as opposed to speaking with it's a family doctor, a nurse, perhaps, what have you, about what the impact of vaccine is for them, given their underlying medical condition. So I think that a couple of things. One, continuing to offer vaccine appointments. And as we open up, of course, more broadly to vaccine in general, that will certainly happen. First Ontario Centre is a mass site, of course, but we have some mobile pop-ups as well. The other piece is giving people the information and time they need. So if they need time to make a decision, that's fine. We can make appointments available later at First Ontario as well. To your point that First Ontario was available all weekend to them, in fact, First Ontario was available each evening, Friday, Saturday, Sunday. However, we still continue to offer other vaccines, of course, through that site as well. And so these were additional slots that were offered in the evenings, and we can do that again.
Thank you. Councillor Farr, that's time for you. Do you want to go on a second time?
That's not time. No, you're just timing questions, right? Not responses.
People have different ways of doing that, but I generally use the full 5 minutes and then get people on again. But go ahead, one more question, and I'll get you on again.
I think I've only taken about 2.5 questions, but thank you. I'm certain that I'll be a lot shorter than some of the opening comments. Through you, Mr. Mayor. Well, now I got to pick between the 2 remaining questions that I have. So socialization to Dr. Richardson then, because when the 235 Rebecca outbreak began, which is among the top outbreaks in our city overall, and something to be concerned about, and I think these questions are important. So through you, Mr. Mayor, to Dr. Richardson, you were, according to today's detailed presentation, you were bang on when you said socialization was the prime culprit here. I'm still hearing socialization today. Somebody said close living quarters, families living together, helping each other. That is basically the point you made a couple of weeks ago. Through you, Chair.
Through you, Mr. Mayor. Thank you, Councillor, for the question. And you know, the terms that we use within the response don't always fully reflect what it is that goes on. And so what I had said earlier was that, you know, there's a combination of things which included people supporting one another, and that by and large, this was driven by people supporting one another in various ways, whether it was helping somebody who was sick, helping with childcare. And I think the explanation that you have heard today from Michelle, a very fulsome explanation as to the factors behind the transmission that we've seen. And as both Jordan has said and Michelle has said, really understanding what those factors are very important for people to know. as we go forward, because it gives us the basis for what we need to do today around COVID, but it also continues to point out the issues from a social determinants perspective and what society needs to consider going forward.
Thank you. Councillor Farr, I'll put you on a second time. Sir, thank you. Councillor Wilson.
Thank you. I really appreciate those last line of questions from my next door colleague. I have a lot of misgivings personally about the use of vaccine hesitancy. And I was going to ask, do we have an official public health definition of it? Because I think what is used publicly is different than even some of the factors that I heard Michelle reference what might be causing vaccine hesitancy. For example, not being able to access a clinic because you don't have the transportation. I didn't appreciate that we fold that in to vaccine hesitancy as opposed to that's a social determinant of health because they don't have access to vehicle or they live in a they don't have the income for mobility. Could I have an answer to that? Do we have an official definition of what vaccine hesitancy is? Is there one province-wide or regionally?
Through you, Mr. Mayor, if I can, and perhaps then I'll turn to Jen to speak to it. Essentially, what we've been looking at are all the factors that might lead to a barrier to somebody getting vaccinated. And so we don't know before we talk to people what factor it is that is, for that particular individual is causing them not to go forward with vaccination at a particular point in time. We may make an assumption that it's that they don't know something about the vaccine and its safety. We may make assumptions about various things, but what's very important to do is to talk to people about what's really causing them the challenges in terms of going forward to be vaccinated. And for some people it's about transportation and access to transportation. For some people, it's that they have a number of children and they don't want to go out and take their children with them to the vaccine clinic, or they're worried about the kind of environment that they might be in and whether that would be difficult for them. For others, it is about information. For some, it's about they need to understand it in their own particular circumstances. So the term is very broad in terms of its application and really meant to be the starting point for a discussion about what can be done to help relieve those barriers. And so I'll just see if Jen wants to add anything there.
Thank you.
Thank you, Dr. Richardson, and through you, Mr. Mayor, to the councillor. It's a good question. I think it is really important to differentiate social determinants of health that are some of the root causes in terms of access and equity, which is a different issue altogether. I will say PHAC, Public Health Agency of Canada, does talk about vaccine hesitancy. It does tend to be the language that's used in our community that's familiar to folks. More and more, though, is the use of the term vaccine confidence. And that is more about the trust that individuals have in vaccines, the providers who administer vaccines, and processes and policies that lead to vaccine development, authorization, manufacturing, recommendations for use. And that's a definition by the CDC. So they do have slightly different meanings, but I will say the preferred terminology now is vaccine confidence, and you heard me refer to our vaccine confidence team. They have named themselves that way for this reason. So PHAC does have a definition of vaccine hesitancy, but it does imply that individuals are reluctant to receive vaccinations because of concerns or doubts about the vaccines. And so vaccine hesitancy can change across time, place, and vaccine. So thank you for your question.
Thank you. Councillor Wilson.
Thank you. So my next question has to do with, I know is rooted in my own limitations with data. I am trying to understand what this data is telling us and how it is informing our strategy moving forward. So if I strip it away through a number of layers, as we worked our way through the presentation, it started out by telling us that 45.1% of the eligible population has been vaccinated. And I took from your comments that that is relatively on par with the rest of the regions in the province. And then the next slide told me that for First Ontario Place, 36,000 people have been vaccinated there. compared to 30 point, almost 31,000 at mobiles and 27.5 at pharmacies. I'm trying to get to the very root of these determinants. And then there was two subsequent slides. Forgive me, I don't have the numbers. There was a slide which told me the estimated vaccine coverage by age, followed by another slide which gave me the estimated vaccine coverage by forward sortation area. What is not clear to me in that data is, say, how is the age group, say, from 60 to 69 in one postal code faring to the age group of 60 to 69 in maybe a code red postal code. And it's linked back to my first question. I was surprised to see the number of vaccinations at First Ontario Centre, which was designed to be efficient, getting as many jabs in as possible, was relatively on par. Maybe I'm not reading it right, but with the mobile clinics. And I'm trying to determine what is the threshold against which we are saying there is a subset of population here that the First Ontario Centre is not working in a way that it worked for a certain segment of our population, but for this hesitancy or confidence, it's not working. It's not working. This is a hypothesis. What are we using to determine the interregional components of how we're getting that vaccine out?
Okay.
Thank
Michelle?
you.
Through you, Mr. Mayor. Thank you for the question, Councillor. I think there are a couple pieces to this one. As a starting point, it's sometimes difficult to compare First Ontario to the mobile sites. All of this really up to now is very much driven by supply. So we were the supply we would receive, we tried where possible to maximize that supply through the mobile pop-ups, and such, because we know that those are getting directly into the clinics. First Ontario has not been operating to its max capacity for weeks, really, because we don't have the supply to allow that to happen. Basically, we were having to make choice between putting supply to the large scale clinics, the 3 that we have, or putting supply to the mobile sites. So it may appear that the flow, the throughput is higher on a sort of per vaccinator site at the small clinics, but really it's that we were diverting supply intentionally to those areas as opposed to into the large scale clinics. You will see as we go forward more supply now that we're in a place where we have a better supply volume, that the throughput at those clinics, be it HHS, St. Joe's, or FOC, will increase, and will increase significantly in comparison to the mobile. The mobile continue to be resource intensive clinics to offer, and although they are right in those communities and sometimes make sense for populations. If you think of a population like the farm workers, for example, that makes very good sense for mobile, but the large scale clinics will have a larger throughput overall on sort of a longer basis now that we have the supply to run them at capacity. The mobile sites have basically been running at their mass capacity for weeks now, so you won't see the growth in that particular throughput. With respect to reason for vaccination and how we display the information, there is some double counting here, and there are at times groups counted in one bucket where you might think they could be counted in another. For example, when you come to get your vaccine, you would indicate your reason for getting a vaccine. Lots of us might have lots of different ways that we qualify for vaccine. So you might say that you're there because you're over the age of 40, when really you're also an essential worker and perhaps you live in an FSA where we're trying to prioritize vaccine. So it doesn't necessarily capture everyone in there. On the FSA front, we can look a bit more at what data we can get, but I will say it's challenging with the systems we have to really slice the data in all the ways we would like to do so. I'm hoping that answers a bit of the question.
Would you be able to update us when you might be holding those spots for the residents of 151 Queen North?
Through you, Mr. Mayor. So for the other two apartment buildings, the issue with vaccine is that everyone that comes into the clinics, whether they be mobile or on-site clinics, do need to go through a screening process. And of course, we can't have cases, whether they're symptomatic or asymptomatic, showing up at clinic. And so we needed to have everyone tested, receive all the test results back before we could stand up clinic times, because one of the screening criteria really is are you a contact of someone with COVID, or have you been tested recently? These are the types of questions you're asked. So individuals wouldn't be able to get vaccine. So as of, I think today, we do have the results back from those buildings. And so we will be working with the building administration at both to set up, they'll be coming to FOC over the next couple of days, likely Tuesday and Wednesday, working with them right now.
Thank you.
Going back to my second last question,
Oh.
if I could. Thank you, Michelle. I kind of understand what you're saying about double counting and whether someone self-identifies as an essential worker as the reason for getting their shot, or as an older resident for the reason getting their shot, or a racialized person for the reason getting their shot. But do we have any data which could inform us how Hamilton is faring compared to other jurisdictions in the province for getting shots in arms, if you will, to the various categories?
Thank you. And that'll be time for you as well. Michelle, go ahead.
Yes, through you, Mr. Mayor, we do have some of that data. I'm not sure how much we have on an FSA basis, but overall, I can tell you that on an overall basis, we are lagging a bit with respect to the rest of the province on an overall coverage rate. However, there are certain populations for which, we're quite far ahead of where others might be. Again, because we very much chose to target our approach to certain populations. So I can give you an example. For example, the homebound population in Hamilton is quite well covered, as well as the healthcare worker groups, maybe compared to other areas. So we've been really trying to target where possible, and then of course use the broad perspective. So I would say the answer to that, Councillor, it's different on an overall basis as opposed to with specific populations.
Thank you. Councillor Nan. I'm just mindful of the time. We do have delegates, and I know that Public Works starts at 1:30. So just be mindful of time, not suggesting anything other than be mindful of that. Councillor Net.
Thank you. Yes, I can appreciate that. It's hard to get all these questions in given everything going on right now. But two realms that I had hoped to ask questions around. One is around vaccine health and equity. The other was around the apartment. So I'll start off with vaccine access. So through you, Mayor, to Dr. Richardson and team, thank you again for the thorough report. As vaccine eligibility opens up to those who are at lower risk, province-wide 18 plus as of tomorrow, there's concern in the community that those who've been continuously experiencing greatest risk of infection and death are going to be deprioritized. Could you speak to how we are going to pivot the strategy to continue working through hotspot locations and those who are facing greatest risk? Are we going to see mobile pop-ups be dedicated specifically to hotspot populations and those who are still greatest risk? Are we still running all of these things concurrently to the province opening up province-wide 18 plus?
Right. Michelle?
Yes, through you, Mr. Mayor. So yes, as we move forward with the province opening up overall, this is again an opportunity for us where the general population, of course, can go to all the clinics, and the clinics will be available to them. But we will continue our targeted work with the priority populations, be it in those FSAs and in some cases beyond with specific populations. We'll continue to look at our own metrics with respect to vaccine to see where we need to focus efforts to ensure the right people are receiving vaccine and overcoming barriers.
Thank you.
Thank you, through you. So then when we look at those stats that were shared today of the FSA vaccine rate, so L8L hitting at about 28%, L8N hitting at 37%, compared to another hotspot, which seems to be tracking quite well, L9K, which is at 44.9, which is close to our citywide average. So from looking at the data and knowing the kind of on the ground effort that's underway with community neighbors, getting out the information, I know that L8L probably tracked higher, or sorry, L8N probably tracked higher than previous report because of some of that ground effort going in and helping residents know that they're eligible and getting in there. The one thing that comes back as feedback on the ground is even in a community like L8N, where Bernie Morelli Center has been set up as a mobile clinic, where FOC technically doesn't appear to be that far away, but from a transit perspective and on those other points that you mentioned, Michelle, in terms of residents wanting to hear from their primary care provider and doctor, is there any chance that we'll be seeing increased pop-up locations there or working again with the pharmacies? For example, I know that the Cannon Street Shoppers, which signed up to be a vaccine distributor, still hasn't received any supply, and that location would be so close from a proximity perspective for the outbreak that's happening at Wellington and Cathcart, as well as for those who are in L8N.
Bill?
Yes, thank you, Councillor. Yes, so we would be looking at that FSA information and again, going back to our vaccine readiness network, our partners in the community and whatnot, and talking about what strategies basically among our toolbox would work in those areas and how do we continue to increase uptake. So it might look like what's happening elsewhere. We wouldn't be in a place where we can add an FSA as a hotspot. There's lots of challenges around that, as you know, and that we have to use our local booking and whatnot. And so we're in a place now where it's more preferable that we target in different ways. With respect to pharmacy, I'll just give you a brief update that yes, we do have some pharmacies within those areas that ideally we would certainly have liked to see vaccine flow through as well. And we have some strong community supporters among the pharmacies there for sure. Pharmacies overall, as we move into a more sustainable vaccine structure, when we get to more what would be business as usual, we're hearing clearly that pharmacies across the board are going to start receiving vaccine, and it would be an expansion of the Moderna Pfizer offerings as opposed to what's in place now. So some of those pharmacies you will see. In fact, over the next couple of months, you're going to see that all the pharmacies that are UIIP approved, which really are those pharmacies that offer flu vaccine, that they'll be in a place where they'll have Moderna or Pfizer. And that is part of trying to build sustainability, build local access. And you're going to see that happen through primary care as well. We'll have lots of additional opportunities for Moderna and Pfizer vaccine too. So people are going to start to see right within their community lots of those locations where they normally get vaccine, where their trusted providers can be consulted with on site. And so this is all good news for our neighborhoods for sure.
Thank you.
Thank you. Hopefully that shoppers at Cannon can get that supply up because that would make such a difference for outcomes of vaccination rates increasing for both L8R and for L8L. In terms of the vaccine ambassadors, if I could through you, are they also, have we made sure that they're all vaccinated prior to engaging in their community work?
Through you, Mr. Mayor, yes, they will be receiving vaccine or will already have received vaccine. Anyone who's working in a vaccine clinic, be they an injector or one of our non-clinical supports, and in this case, including our ambassadors, are of course eligible to receive vaccine. So that happens with our deployed staff at FOC, that'll happen with our ambassadors, that happens with the folks working in the mobile clinics. So yes.
Thank you.
Thank you. And so in terms of the apartment, so how many people in total are we looking at in terms of population in the 3 buildings?
Across the 3 buildings, there are over 1,000 individuals living there. There's just over 1,100 across the 3. That includes the Cathcart portion of what I'm calling the Wellington, the 125 Wellington 50 Cathcart.
Got it. And so that was helpful earlier through you, Michelle, when you mentioned that folks in those outbreak apartment buildings first need to be tested in order to be slotted in for vaccination, in order for us to manage no further outbreak or spread. Of concern is the fact that these residents are largely essential workers, and the thought that they are either contracting or potentially spreading at workplaces. I guess I'm still a little stuck, and I look forward to the ongoing conversation about how we can blitz a population of 1,100 people to be vaccinated, given the spread potentiality here, not only of the existing apartment buildings continuing in their outbreak, but the potentiality of that contributing to workplace spread, which was the highest, right? Highest percentage of outbreaks is in workplaces in this city. And of those, it's the kinds of places where these residents in these apartment buildings are working. So to me, it kind of, it just doesn't, I don't know how we triangulate that in terms of priority, though I do appreciate all the efforts that are underway. I guess I'm still stuck on the ability to vaccinate on location versus overcoming those barriers that were identified previously.
Thank you. And that's time for you. Thank you. Take that as a statement as opposed to a question. Councillor Danko, you're up next.
Thank you, Mr. Mayor. Actually, I had a question about just a summary of the who is eligible for vaccines and where, but seeing the, because I've lost track, but seeing the announcement from the province that as of tomorrow morning at 8 a.m., all Ontario residents, I think it is 18 plus, will be eligible for vaccine. It's kind of a moot point. So maybe I just get confirmation. I think that's breaking news that that's the announcement as of tomorrow morning.
All right, Michelle, have you heard that announcement, or Dr. Elizabeth?
Yeah, through you, Mr. Mayor. That is the current status as of tomorrow morning is what we're hearing as well, which is great news for all of us because it does allow some clarity. I hear you completely that there's been confusion in lots of areas with respect to who's eligible, how they book, where they book, and whatnot. So this will mean everyone in the province is eligible to book a vaccine if you're 18 plus and can book through the provincial online tool, which is welcome news, certainly for our community.
Thank you.
That's absolutely amazing news, and I know it's going to be very, very welcome by everyone throughout the city that has been very anxious to get their vaccine, and when's their turn now. It's everybody's turn, which is just absolutely fantastic. So follow-up question on that then is for youth, 12 to 18. I believe some of our neighboring municipalities have already started vaccinating youth, and I think in that announcement, the province has said May 31st will be the date for starting youth. Is there any chance that we'll be able to advance that?
Through you, Mr. Mayor, likely locally we wouldn't be starting in advance of that. Most of our vaccine allocation and appointments are already on set to our clinics, basically allocated to the clinics that we have in place. So we wouldn't have supply before that, but we will be prepared to start at that point in time.
Yeah.
Great. I know, again, there's, especially some of those younger retail workers that are essential and are working right now. I'm looking forward to getting vaccinated, and also the impact that will have on back to school in the fall is just absolutely enormous. Last question would be just on the overall vaccination program as of right now. It's on the individual to kind of find out where you can get vaccinated and book your appointment. Has there been any discussion internally behind the scenes with the province, perhaps, of turning that around to offer people pre-booked appointments and just contact them and say your appointment is on this date at this time? Because I assume we already have a database of everybody that's already been vaccinated through your health card. So instead of having individuals have to go out and book an appointment, just turn it around the same way we do with registrations for elections.
Thank you. Michelle?
Through you, Mr. Mayor, no, at this point in time, that's not something that's been considered. Again, vaccine is, and the choice to accept a vaccine really is an individual choice. So we would be taking away that choice should we provide appointments to everyone. The other piece, of course, is that lots of people are still at work and still have commitments, and so giving people dedicated appointments doesn't always work. So at this point in time, it is at the individual level to book an appointment. And I can tell you that what we hear through people that are able to book on the online tool, or even through the phone line lately, but the online tool really is fairly straightforward. It just takes a couple of minutes, and people do have choice with respect to where they receive their vaccine.
Thank you.
Thank you, Mr. Mayor. Those are all the questions I had.
Thank you very much. Councillor Danko, or sorry, Councillor Clark. And thank you, Councillor Danko.
Good morning, Mr. Mayor. Thank you for the time.
Good morning.
Quick questions around vaccine hesitancy, which now equates to vaccine confidence. My concern is more around vaccine impediments. For example, language. Are we communicating to the different communities in our city in their own language so that they can understand it, especially newcomers who have come into the city and don't speak English, or at least it's not their mother tongue?
Thank you. I think Jennifer Vickers-Manson covered that earlier on. Jennifer, do you want to speak to that again?
Through you, Mr. Mayor, to Councillor Clark, thank you for the question. Yes, you are quite right. Having vaccine information accessible in your own language is really important. We do have information on our website translated into multiple language. You'll recall that I highlighted, this is our shot campaign, also has multiple messages highlighted. In addition to that, through our engagement sessions with the groups that I identified while I was speaking, we co-created relevant fact sheets and tailored materials for relevant populations, and we translated those into French for those populations, and they can be translated into other languages as well. I will remind folks that they do have access to translation services both through the provincial phone line as well as our local public health vaccine booking line. In addition to that, should they arrive on site and want translation services on site at the vaccine clinic, they can also access translation services on site. In addition to that, the 10 ambassadors that we hired that are representative of all racialized populations in our community also were hired for their ability to speak more than one language. So those are some of the efforts that we have underway. And then, of course, back to this collective impact approach in that we are, through our Vaccine Readiness Network, engaging with our community partners that do also have multiple languages resources, and they are amplifying our messages from what they are hearing at the Vaccine Readiness Network and where they are engaging with their populations as they do so through their regular programming.
Thank you very much. That's very helpful. I'll be sharing that with my residents, who especially have been asking about that, and they're new to the country, and so they were struggling trying to find information. The next question I have, Mr. Mayor, is on slide 3 of the presentation that showed 45.1% vaccinated. I'm assuming that is a one-time vaccination rate. Is that correct?
That is correct through you, Mr. Mayor, that is for a single dose vaccine.
Do we have any numbers on double dose? Is it called double dose or totally vaccinated? I don't know what you call it, but the folks who've got both shots, do we have numbers on that yet?
Through you, Mr. Mayor, we do. My apologies, I don't have it here in front of me, but I can tell you it's much lower, of course, that when we moved out to the 16-week vaccine dose interval on March 10th, the majority of folks from there on out, of course, have received a single dose of vaccine.
And to that second, I would like to have that information if we have it. I know it would be much slower, but do we have any information yet as to the efficacy of the vaccine when it is delayed to such extents? I understand the delays were made because we didn't have the vaccine quantities in the province, and so the decision was made to extend the second dose out. Do we have any studies yet that have indicated whether or not the vaccine is just as effective or less effective?
Michelle?
I'm going to turn that question over to Dr. Richardson perhaps to answer, but on the first piece of your question, Councillor Clark, Steph has updated me very quickly to let me know that 3.9% of Hamiltonians have received both doses of vaccine.
3.9%, did you say?
That's correct.
Thank you very much.
But the number was something like 15,000 earlier on that got 2 doses until that stopped. Yeah. Dr. Elizabeth?
Through you, Mr. Mayor, to the councillor, in terms of the efficacy, in terms of the long extended second dose, the information that we did have came from those initial studies with the vaccines that looked at those who did, for whatever reason, need to have a longer vaccine interval, showed that it was still, you had good vaccine coverage with the 1 dose. Reaching, particularly for Pfizer and Moderna, into sort of high 80s, low 90s sort of rates of efficacy once you were out at that 4-week point, and then continuing on from there. From basic immunology and vaccine principles, we do know that when you extend that time interval out to the second dose, often you end up with higher final rates of immunity compared with having the second dose of vaccine sooner. So while it does bump you up some more, the longer you have that, it does bump you up further. The specifics with these vaccines continue to be studied. As we go forward, we do know there are subgroups that actually need those 2 doses much closer together to get those higher rates of coverage because of their risks. And so there is a subset of people that are continuing on a shorter 2-dose strategy. And as well, as of last week, our highest risk healthcare workers who are working in ICUs, emerge departments, but also in testing centers and those sorts of settings have also been moved up in terms of their second doses and are being contacted to get their second dose shots rescheduled. So as we go forward, they'll continue to review and see if there's other particular groups that need to have that interval shortened, and we'll continue to gather more information, more science, more studies about ultimately the optimal timing of second doses.
Thank you.
Thank you, Mr. Mayor. And with regards to the highest risk health conditions or high risk health conditions, how does a patient or a resident ensure that they're getting a timely second dose if they have a challenging health condition? Is it their family doctor that provides them a note? How do we verify? Because you can have anyone coming forward and say, I'm in the highest risk health condition. So how do we verify that to assist those residents in getting their second dose in a timely manner if it's needed that way?
Thank you.
Through you, Mr. Mayor, there's been a lot of communication with the physician community, the healthcare community, the specialists who look after these people who would be in that highest risk group, and that subset of them that would need to have that shorter vaccine interval. So for example, people with cancer who are under active chemotherapy would be included in that group. And so there's been lots of messaging through many, many different routes to let people know about the fact they do need a note from their provider to say they belong to that particular group. And then they give us a call and we book them in for their vaccine.
Okay, those are all my questions. Thank you. This was a very comprehensive report. I appreciate it.
Indeed it was. Thank you. Councillor Pearson.
Thank you, Mr. Mayor, and certainly thank you to staff. And it really was good to have the presentation because a lot of questions were answered that I had. But just a couple things, just clarification on the pop-up clinics. I know there were a couple that were set in Stony Creek at the Salt Fleet Community Center, and I'm getting more and more emails of residents saying, why can't there be a clinic set up at the easterly end of the city that residents don't have to go all the way downtown? And I'm not sure who would like to answer that. I think it was Michelle that spoke to the clinics earlier.
Thank you. Through you, Mr. Mayor. And yes, we were at Salt Fleet Arena earlier this year, and we will return, of course, for second doses, so folks don't need to worry about that piece. With respect to ongoing clinics, I mean, we have limited resources with respect to our mobile teams. And we did start doing those more outlying areas with mobile when we were looking at the 80 plus, the 75 plus, and now that we're into the younger age groups, we really are trying to bring folks into the large scale clinics, and appreciate they are all closer to the downtown at this point, and we can continue to look at that. But we're trying to use our mobile clinics to reach those hard to reach populations that we spoke of earlier. However, we're also looking at sustainability measures that we talked about, like moving vaccine into primary care practices, and we have a couple more of those coming on board. You're going to see expansion increase rapidly in the pharmacies as noted, so there'll be opportunity in pharmacies for folks to receive vaccine regardless of which part of the community they're living in. So there's certainly pieces of work underway that you're going to see vaccine come into Stony Creek again.
That's great news, and I appreciate that. Certainly for the residents have contacted me, and I've expressed them. I mean, there are the limited resources. So with that, I just want to mention my husband was thrilled that he did get his vaccination, his first one on Saturday at the Hamilton Health Sciences on Wellington Street. Again, I had mine just over a month ago at First Ontario Centre. Both facilities, absolutely phenomenal. I think if you had every station manned at the Hamilton Health Sciences site on Wellington, it looked like you could have had 60 stations set up. And I was told going in that they were anticipating 1,200 vaccinations being administered there on Saturday. So great news, and kudos to all staff, because I see the monumental task and being sure people get in. It's not just putting the needle in the arm, it's all the paperwork that has to be done and the waiting period. So there's a lot more than just getting a needle in the arm, and I appreciate that. One other question I want to ask is, and it was on the news, I'm sure everybody heard it, Peel, I think it was, went into an overnight vaccination center. I think that happened Saturday night. And they said that other communities would certainly be keeping a watch on this. Has Hamilton, are we gauging how successful they were? And this was to get, the workers that are, maybe shift workers or people working in the day that can't make it in the evening, or just as it was said on the news, somebody's just up at 1 o'clock in the morning and, hey, I want to go get my vaccination.
Yeah. And, just a reminder, Peel, Toronto, and York are getting significantly more vaccine than we are at this moment. So,
right.
Michelle?
Thank you, Mr. Mayor. Thank you.
Yeah, through you, Mr. Mayor. Thanks for that. For us, certainly supply does drive some of this. I will tell you, though, we are looking closely at what Peel did, and there were some initiatives in Toronto as well this weekend with respect to longer hours and shifted hours of clinic. And that is something we're trying to incorporate locally, because we have heard from folks, particularly now that we're in those younger age groups, people do work during the day. So, those early morning hours and those late evening hours work perfectly for some people. And so certainly we are looking at how we can expand out our clinic hours, at least in some of the sites.
Excellent news. Thank you very, very much. And to everybody, it's been a superb, stupendous job that's been being worked on now and moving us forward. Thank you for that. Thank you, Mr. Mayor.
Thank you. Councillor Ferguson, I saw, had a question.
Yes, thanks very much, Mr.
Okay.
Yeah, thanks very much, Mr. Mayor. Oh, I'll turn my camera on.
Yep.
It's a nice story today. It's nice to see some progress.
Your audio is a little distorted. You might want to turn your camera back off just to make sure we can hear you properly.
Okay. I hope that's better. Can you hear me better now?
Yeah, very
perfect. Good. Okay, so it appears that we're making progress on the first shot faster than what we originally anticipated we would, primarily, I guess, because the amount of vaccines we're getting is increasing exponentially. So we may be getting to the second shot sooner than what we originally thought we would. If that is true, how will people know if they have been advanced? Because when you got your first shot, you were given the date for your next one, which, for people in the 60 up here is sometime in July or early August. If we're able to move this up sooner, would the people looking for the second shot need to apply again, or would they be contacted that they can get an earlier date?
Thank you.
Through you, Mr. Mayor. So it's called the second shot strategy when we talk about it at the Provincial Vaccine Task Force. And, it's been focused right now on those who, for medical reasons, need to have those vaccines in a shorter period of time. And those are the ones we've talked about already, the subset of those highest risk groups from a healthcare perspective. And so that has been going forward, continues to go forward. And as they become as additional groups get added, as pregnant women were, for example, pregnant people were, that was added a little while ago. And so the notices go out to the providers, to the public, to all sorts of people to help connect with people and make them aware that that's happening. For healthcare workers, as you know, they were added as well, particularly those that are at highest risk of COVID exposure. And so, you know, ICUs, emerge departments, COVID wards, all of those sorts of groups. And so they're notified, by and large, those people were notified through their employers in terms of their eligibility. And we're continuing to work with the smaller employers. You know, the hospitals are working directly with theirs, but we'll work with the smaller employers to make sure that they're notified that they are eligible for that second dose. Because of the way we did that that strategy at the time, we do have contact information. And just in response to Councillor Danko's question earlier, of course, we don't have contact information. It doesn't come along with a health card, unfortunately, a health card number. And so we did, in the case of those healthcare workers at the time, have contact information added. And so we're reaching back out to those people directly to let them know that they are eligible and indeed rebooking those appointments. So as this view to who needs to get the second dose earlier because of either their personal risk around their own health status or because of their exposure status as they help to care for all of us, there will be a continued strategies to notify those specific groups or the caregivers of those groups or things like that. As they continue to look at what they might be able to do on a broader basis, I expect will by and large be dependent on public notification through media channels, social media channels, that sort of thing. And as that unfolds, because there's, you know, no specifics about that yet, that's just an idea that's being worked through. We'll know more about it and can look at what are the best ways to move forward in notifying people that they are eligible.
So those people who are, say, over 75, who had their second vaccine booked for early, middle July, if they can come in sooner once you've done those people with the underlying health problems, they'll have to go into the provincial portal and try to get an earlier date then, will they? Or you're not clear yet?
Through you, Mr. Mayor, there's no clarity at this point about exactly what will happen, but ideas about how people can rebook their second dose are definitely being considered. It's a challenge potentially for all of us as we look at, you know, when those were booked. You're just given a second appointment for a date and time, and things may have changed in your life, and you may need to move that around. And so the province is trying to make a solution that is that can be used by people, whatever the reason is that they need to rebook their second appointment.
Okay, thanks very much.
Okay, thank you. And back to giving the chair to Councillor Wilson. Just a reminder that, you know, that we're you know, going to be soon into second doses. So, you know, of the 500,000 plus people we have in our community, and hopefully 70 or 80% of them will take on this vaccine. We got to do this all over again. And I just want to thank our good staff that have done an amazing job of pulling this together on an ongoing basis, given all the challenges out there and all the different opinions and how to do it better. They've done a terrific job of I think managing all the input that we've received and all the advice that they've been searching for with all of the partners that are out there doing this work. They have my 100% confidence that they're doing this in the quickest, most effective, and fair and equitable way possible under the circumstances. So I'm really delighted with the work. Dr. Richardson has done a terrific job. Michelle, Jennifer Vickers-Manson, and all the other team members and all the unseen ones. And I would say that there's possibly 25, 30, 40 other people that are all putting their minds to these issues on a day-to-day basis on how to do this best. They have my full confidence. I think they're doing a terrific job. We need to have confidence in our public health team. We need to have confidence in their ability to do it fairly and equitably. And I hope this council, also, or this Board of Health also supports all of their great work going forward, because that really is going to matter, as well as the hesitancy and some of the other impediments that we see out there in terms of people getting the vaccine. So I just want to give our good staff and their approach to all of this my vote of confidence because I think they've done a terrific job. On that, I see no further speakers, so I'll take the chair back, Madam Vice Chair, and I will ask for a motion to receive the staff report. A mover, Councillor Pearson, thank you. Seconded by Councillor Jackson. Thank you for that. And we'll go to a vote to receive that fulsome report. And I think it was beyond comprehensive. And I do anticipate and expect that our good staff will operationalize all of the good things that we've discussed today on an ongoing basis. And everyone able to vote, Madam Clerk?
Through the chair, I'm waiting for Councillor Ferguson.
Okay.
Okay, thank
thumbs
you. I
up.
see his thumbs up. Vote is closed, and
Thank
that
you.
carries 13-0.
Thank you very much. We do have delegations, as we spoke to earlier. We have first up, item 9.2, Emily Power, with apologies, a long wait, respecting the urgent need for a more proactive strategy to arrest COVID-19 outbreaks in apartment buildings. Topic of conversation today for sure. Emily Power, are you with us at this point? I know someone had to drop off.
Hi there. Yes, I'm here.
Okay, thank you.
I had
Good
some
afternoon.
issues sharing my screen before, but I'll try.
Okay. Delegation time for you is 5 minutes, so floor is yours.
Does that look okay to everybody?
We can see it.
Okay, wonderful. Okay, good morning, Mr. Chair, and well, I suppose we're good afternoon now. My apologies. Members of the Board of Health, my name is Emily Power. I'm a tenant in the Gibson-Lansdale neighborhood. I was an organizer with the Hamilton Tenant Solidarity Network, a tenant group that was active in Hamilton for 5 years, from 2015 to 2020, helping out in hundreds of tenants, dozens of buildings across the city, including key fights around the Greenwind case at John and Rebecca Towers, the Stony Creek Towers fight over the above guideline increase, and Metrolinx related evictions of tenants along King Street. But most recently, I've been supporting tenants living at the Rebecca Towers, an apartment building nearby where I live. All right, here we go. The Rebecca Towers crisis has shone a light on the city's failure to anticipate outbreaks in apartment buildings and plan accordingly. Especially with the new highly contagious variants, I fear that many tenants across the city will get sick and some may die. So it is pressing that we act now. There are approximately 85,000 Hamiltonians living in apartment buildings 5 stories or greater where these kinds of outbreaks could happen and be devastating. Most of these high-rise dwellers live in wards 1, 2, and 5. I counted approximately 250 mid and high-rise buildings across the city. Here we can see the most recent data for COVID cases by census tract citywide. Here we can see the detail of the lower city. Many cases are in areas where there are clusters of apartment buildings. It appears many of the working class neighborhoods in the north and east end of the city have some of the highest rates of COVID infection, while also the lowest rates of vaccination, and this is very troubling. There are many densely populated apartment building neighborhoods with very low rates of vaccination as compared to wealthier areas in the suburbs. The current outbreaks at 235 Rebecca, 125 Wellington, and 151 Queen likely will not be the last. The combination of low vaccination rates and high density apartment buildings is a recipe for disaster. There will likely be more apartment building outbreaks in L8R, L8P, L8H, L8E, and L9A in a matter of time if action isn't taken soon. And here are the 3 cases reported so far. 1 person has died, and As many tenants see the situation, we fear many more tenants will die if public health staff do not change their vaccine strategy. These are some of the reasons working class people and tenants in particular have a hard time accessing vaccines under the current strategy. You can see the full list, but I'd like to highlight the reasons on the right for the tenant living in a building with an active outbreak. Tenants are very fearful of leaving their units to travel to mass clinics like First Ontario Centre to get vaccine, as they risk catching COVID or sharing it with other Hamiltonians en route. So here are my suggestions for what the city could do now to avoid this coming crisis. First, be adaptable and responsive to the need. Change the vaccination strategy to bring it to working class people who've been left behind and who need it most. Allocate money from the $45 million in the emergency pandemic funding from the province. Work with the primary care team to deliver vaccines to apartment buildings through pop-up on-site clinics and door-to-door as a proactive measure to save lives rather than a reactive strategy. Doctors and pharmacists have already said they're willing and able to do this and have experience doing it well in the shelter system and at long-term care homes. Next, track case counts at apartment building addresses to anticipate outbreaks, notify tenants early on. Similar work has been done by St. Joe's staff to track cases in shelters and other outbreak settings, and they've offered to do the same for apartment buildings. Lastly, work with tenants to identify poor building conditions that might contribute to COVID transmission rather than blaming tenant socialization or negligence. These kind of on-site clinics have been done in many Canadian cities, including Ottawa and Toronto. And, for example, in one weekend in the working class neighborhood of Jane and Finch, nurses and paramedics were able to deliver over 3,000 vaccines in this manner, both through the on-site door-to-door vaccinations and the pop-up at a nearby park. And we can do this in Hamilton. Indeed, we already have. So just yesterday, Sunday, May 16th, a door-to-door on-site vaccination clinic was held at the Rebecca Towers, and it was a great success. Here you can see the doctors in action, giving the vaccines to some very happy residents. 28 tenants in total received their shots. And I'll end with this quote from one of the Rebecca Towers tenants, Arifin. If I have time remaining, I'm not sure. Please interrupt me if not.
No, you can finish your quote.
Great and exciting. Sorry?
Yes, you'll finish your quote.
Thanks. Today was a great and exciting day for me and my family living at Rebecca Towers. Despite having an outbreak in our building and my family contracted COVID, we can still see some lights around the corner. Raising demands finally brought Hamilton Public Health to provide vaccine at our doorstep. Me, my wife, and my mom all got our first shot. We are feeling safer now as we try to give good care to our newborn daughter. Remember, this is a gentleman who could not even kiss his or hold his newborn daughter. She was born 2 weeks ago and he couldn't even see her. I especially thank the doctor and their team who did a tremendous job to fulfill our immunization demand, and also Rebecca Towers Tenant Committee who has stood together to unite all tenants for their health, safety, and well-being. I urge city councilors and public health staff to take these points on board and act with urgency. Working class people are the backbone of this city. We are the people who have sustained the city through this terrible pandemic, doing important work, and we feel that we deserve to have the vaccine brought to us to save our lives.
Okay, Emily.
Thank you very much for your
time. Thank you. Appreciate that. Could you take your presentation down for me, please? We can see all members of the Board of Health. And are there any questions of Ms. Power?
Is there a way for me to, I'd like to see your faces. Okay, I see it now.
Okay, thank you. So questions? Councillor Wilson.
Good afternoon. Excuse me. Good afternoon, Emily. Thank you very much for that presentation. I trust you were you here for our earlier okay, thank you. The issue of vaccine hesitancy versus access, and you've highlighted the issue of high density and all the at-risk determinants that many of the residents are bearing. What do you think in your consultation with the residents of Rebecca in this case is the number one factor that might be frustrating their efforts to go to a vaccination larger clinic, if I could, through you, Mr. Mayor?
Thank you.
I think on the whole, the tenants do take the virus very seriously and have been wearing masks and washing their hands and remaining in their bubble as much as possible with, given the conditions in the building. In this case, people were fearful to even and leave their unit to bring their garbage to the chute. People haven't been doing laundry. We've had to organize special teams to deliver groceries to people. Given the ventilation problems in the building and the severity of the outbreak, people are just desperately scared to even step out into the hallway. So the idea that, the city's proposed plan was not to provide any kind of on-site vaccination, but instead to shepherd everyone to First Ontario Centre, the mass clinic, and by school bus. So for a half-hour block of appointments. So, some people took them up on that and that's their choice, but many people really were hesitant to enter the hallway, go down the stairwell, or ride the elevator all at the same time as their other neighbors, and then ride the school bus to the clinic, the mass clinic, and then back again. Even if they hadn't tested positive for COVID previously, the simple act of going to get vaccinated might result in them contracting the virus. So people were very, very scared to do that.
Thank you. Councillor Wilson.
Thank you. Yep. Thank you. I have another question. In your experience and in your opinion, Emily, where are residents getting their news right now about COVID, vaccination opportunities, the various staging of the vaccines, things like that? Through you, Mr. Mayor.
Well, I think people, regularly read the spec and watch CH like, we all do. But I know there's definitely a lot of confusion around, how to book through the various portals and which phone number to call and how to figure out, which category you would be eligible for. That's all very overwhelming. And in this case, the tenants were initially told to call the city line, and people were quite frustrated by that because they were just on hold forever. And these people lead very busy lives, working multiple shifts a day and taking care of their families, and they really don't have the luxury of 8 hours to wait on hold to book an appointment. So yeah, I mean, definitely the block appointments at First Ontario Centre where people they didn't have to book ahead and they could just walk in. That was certainly an improvement, but it didn't address those fears that I mentioned earlier around stepping out of the unit.
Thank you. Councillor Wilson.
If you could maybe come back to me, Mr. Mayor, I'd like to regroup my thoughts on my question. Thank you.
Okay. Councillor Nan.
Thank you, through you, Mayor. Good afternoon. Emily, thanks so much for coming in to delegate and for sharing some on the ground insight in terms of what's happening, unfortunately, at Rebecca with the outbreak, and also for the work that you're doing to support those residents who might need groceries, etc. Inside of this situation that I can only imagine how terrifying it is to live through at this time. I wanted to ask you from a preventative approach, because that's where my head's been at ever since the first outbreak in an apartment building was declared identifying all of the mid to high rise buildings in Ward 3, contacting where I can the existing owners, getting in contact with as many tenants as we can inside those buildings so that we can get them proactive information to encourage them to get out and get vaccinated in order to avoid an outbreak in their apartment building. I was wondering on that side, from a preventative perspective, if there's anything you can provide as insight or suggestions as somebody who's done a lot of tenant organizing into buildings where it's sometimes difficult to get in.
Well, I'd return to the suggestion I made in my presentation that we know that working class people live in a very dense way in these apartment neighborhoods. So if we claim to be prioritizing the working class people of Hamilton and our frontline heroes in our vaccination strategy, you know, why not bring it to where they live? Not only would it be, you know, the right thing to do from a social justice perspective, but it's just so efficient. You know, if we can have paramedics do testing door to door, test hundreds of units in one day, surely we could take the same approach to vaccination.
Councillor Nan?
Thank you. Thank you, Emily. Through you, just a follow up in terms of supporting residents to book their vaccines. Any other thoughts there in terms of what we might be able to continue doing to make sure that those residents get their appointments booked as soon as possible?
Thank you for the question. Yeah, I was limited in my time during the presentation, but I would like to correct some of the earlier statements that were made by public health staff. I would say that
we're gonna deal with your presentation actually, unless there's you know, I don't think that needs any correcting at this point. Thank you.
I think it's relevant to the question that was asked by the councillor, if I may.
And the question was, tell me how it was relevant.
About booking appointments. I was just going to relay that my experience supporting the committee in booking appointments at 235 Rebecca was that the tenant committee was instrumental in the success of the vaccination of, I think it was 68 or 69 individuals over the course of 3 days. That, I mean, of course, we are grateful to all of the paramedics and doctors who came both to First Ontario and to the building. But it was members of the tenant committee who, because we have been organizing in that building for so long, had the names, phone numbers, email addresses, you know, language preferences of all of these residents. And on Friday, we probably fielded 300 or 400 calls from people. And because we had built that basis of trust over those many months, I think we were able to direct people to the option that they were most comfortable with. And I think the Rebecca Towers Tenant Committee and the dedication and passion of all of those brave people who work in that, who live in that building, like, sorry.
Okay, thank you. Councillor Nan?
Thank you. Through you, Mr. Mayor, to the rest of Board of Health, and also just trying to make it really publicly clear that we are going to continue doing everything possible for those 87,000 Hamiltonians that live in mid to high rise apartment buildings. Good news is that the province is opening up 18 plus for vaccination. We will mobilize as best as we can through our community partners, through public health, through the City of Hamilton to make sure that our residents continue to receive the information they need and the support they need. I know that the digital access piece has been one of serious concern in some of these outreach efforts and trying to support people to get booked in to be vaccinated. And when we're sitting with the data that's right in front of us, starkly clear, pointing at 26% vaccination rate or even lower in areas that are hotspot, that are predominantly working class folks, that are predominantly essential workers, where that is all going on. I can appreciate that, and I just wanted to say thank you, Emily, for coming in to delegate, and I appreciate your emotion speaking to this, given what tenants are facing right now. Thank you.
Thank you. And I'm going to ask for a motion to receive the presentation. Councillor Wilson.
Yep, thanks, Mr. Mayor. I did indicate earlier that I wanted to regroup with my question. My first response to Emily is showing emotion is actually a superpower, and I really appreciate that. It's a matter of life or death. So I'm really glad you are here today. If I could just ask the question of follow-up, and I think I'll ask it of Board of Health. I'm not sure I still understand what the relationship is. Is it a formal one or an informal one? Because we've talked a lot about today, learning about ambassadors. What is the nature of the relationship between the tenant board committee, or sorry, the name, I've screwed it up, and Board of Health?
Yeah, and I'm going to rule that out of order at this point because we've had our session with our Board of Health. We're now asking questions of the delegate. If you have a question to the delegate, go ahead. If not, then we're going to move on to the next delegate who also has a presentation. And then we're going to get to, hopefully, an end of this meeting, which will allow us to get to the Public Works Committee meeting. So we're not questioning Board of Health at this point or Public Health at this point. You're asking questions of the delegate.
Okay, I'll pose that singularly to the delegate. What is the nature of the relationship between the tenant committee and Board of Health personnel? Thank you.
You must be on mute because we can't hear you quite now.
Sorry.
There we go.
We did meet with public health staff. It, I think, was a productive meeting. However, the tenants weren't really able to participate in suggestions for the vaccination plan. It was kind of a preset proposal, which many of the tenant representatives were disappointed by. But, of course, people are very happy to get vaccinated as soon as possible, so wanted to support with that. But I double checked with several people from the building over the course of this meeting, and they say that nobody knocked on their door from the vaccine ambassadors. So maybe we were told that was going to happen, but it didn't. In any case, I think this building is much more organized than others in the city might be. So I think it's a good idea that program is being rolled out in other buildings. But I think it does speak to the need for greater support for tenants who are so isolated at this time. And the main point I'd like to convey is that the success of the vaccination program at Rebecca Towers is chiefly due to the organizing of the tenants in the building and the fact that they were so connected with each other. And my fear is that if a similar piecemeal vaccination approach of the combination of the mass clinic and the on-site is repeated at other buildings where tenants are more isolated, it could be more of a disaster. And that's why I'd like to emphasize that these on-site vaccinations be offered at any apartment building where there's rising case counts.
Thank you. You've made that point very, very clearly. Thank you. And I'm going to go to, I see no other questions coming up at this point. So I'm going to go for a motion to receive this presentation. Councillor Pearson, seconded by Councillor Pauls. Thank you, Emily, for your presentation, and I do appreciate your passion. Thank you so much. And a motion to receive has been moved. All those in favor?
is now open, Mr. Mayor.
Thank you. Councillor Ferguson, do you need to indicate manually, or are you still there? There we go. Thumbs up. Thank you.
That passes, carries 13-0.
Thank you. I'm going to turn to item 9.4. 9.4. Got it upside down here, so I'll turn it upside down. David Elstrom is here, respecting COVID-19 outbreak in apartment buildings as well. David, you've also been very patient. Apologies for the long wait. Again, 5 minutes is yours. Go ahead, sir.
Okay, through the chair, to the board, by way of introduction, my name is David Elstrom, and I'm a licensed professional engineer in the province of Ontario with over 20 years of experience. Earlier this year, I completed an assessment of an apartment building in North Bay for the health unit there that was in outbreak. It's about half the size of a Rebecca Towers in terms of numbers of people. There were 45 cases, and sadly, 3 people died from that. I'd like to talk to you today about how air moves within buildings, unintentional air moves within buildings. By the end of my delegation, I hope that you will implement off-site air-gapped isolation for people who have COVID-19 and are residing in apartment buildings. And second, I would like to see resources utilized from the City of Hamilton, such as engineers that are on staff, to go in and evaluate buildings that are in outbreak and make recommendations to the building owner as to how they can improve the building and reduce the potential for transmission of COVID-19 within those units. To do that, I'm going to cover 3 points. First point, older apartment buildings are not sealed between units. Second, air movement happens in unpredictable ways in these buildings. Third, contaminants, including the aerosols, respiratory aerosols, and fecal aerosols containing SARS-CoV-2 can build up and spread between people within the units and then to adjacent units. The spread to adjacent units can be shown or disproved by genome sequencing. So point 1, older apartments are not sealed between units. Modern units will have fire stopping between them, but these older apartment buildings, and I've been in many of them, and I've seen the pictures from Rebecca Towers, there are large gaps around plumbing connections between units. So we have direct connections between washrooms, for example, large enough that even rodents pass between them. There are central exhaust fans on these older styles of apartment buildings with a direct connection in a vertical line between units. And if one of those exhaust fans happens to fail or is not functioning properly, there's a very strong possibility for direct shared air in very short distances to travel between units, either through the kitchens or through the bathrooms. Now, there are finally intentional gaps. There's an intentional gap that's under the front door that's to provide air from the corridor under positive pressure into the units to keep the smells and odors and other contaminants within units. Air movement happens from several different ways. There's a stack effect that happens predominantly in winter, and it's like a chimney effect, and it increases with the height of the building and also increases in proportion to how cold it is outside. So what that means is that air can be drawn in through cracks and openings in the lower levels, filters all the way up through the entire building, becoming contaminated, and then exits out the upmost levels of the building. It's well known it accounts for about 20% of air leakage in a building or heat loss in a building throughout the year. There's also wind pressures, which are shorter term, but can be massive in terms of the amount of air that they can actually move from one side of the building to the other. And then finally, there's mechanical pressures or lack thereof. So you can have very strong exhaust that could pull air from areas that it shouldn't be, or you could have no exhaust or non-functioning exhaust. And all of these different pressures means that the air can be flowing in different ways at different times. But units are not sealed, and so air does move between units. And we know this from many indoor air quality studies, especially in the older buildings. So point 3, these contaminants build up, they spread to other units. Stale, contaminated air, potentially with infectious particles, is exhausted from the kitchen and the bathrooms. It's supposed to be. Makeup air should be supplied from the corridors under the door. If the exhaust is weak, those contaminants build up, and it makes it very high likelihood that there will be transmission within the particular unit from person to person. And I think we're seeing very high, extremely high secondary attack rates within the units. And then adjacent units, if there's any issue with air transfer, they can also become infected. And the latest numbers this morning, 221 cases in 3 buildings with apparently 1,100 people. That's 20% in the past month have become infected out of these 3 buildings. And they still numbers seem to be going up. That's more than just socialization.
You have 1 minute left, David.
So because older apartments are not sealed between units, and because air movement happens in unexpected ways, and because these contaminants build up and spread to adjacent units as well as within the units, there should be an order to implement off-site air-gapped isolation to take people out of the building and prevent further spread. And then finally, get engineers in there, evaluate the buildings, use the engineers that are on staff at the city, and help stop the spread of COVID-19. Thank you.
Okay, thank you. Any questions of Mr. Elfstrom? Not seeing any, thank you. Could I have a motion to receive his presentation, please? Councillor Farr.
Pardon the interruption, Mr. Chair. I do have Councillor Farr on the list, the speakers list.
Just seeing it now, yep, thank you. Councillor Farr.
Well, I want to thank the delegate. My question would have been directed toward the clerk on when would be an appropriate time to sort of follow up on the delegates' good points. I think given what we've heard, questions and comments I've had in the past, we're at a point, Mr. Mayor, where we kind of investigate and report back on some recommendations to Board of Health or GIC with respect to this airflow and mechanical deficiencies and other issues, and especially older apartment buildings. It wouldn't hurt to ask staff, through you, Mr. Mayor, to the clerk at the appropriate time, I'll ask whether that should be a direction or a motion, but it is based on the content from the delegates' points made here today. And again, I appreciating that he hung on like he did. Thank you.
Okay, thank you. And I then have a question of our staff through you, Vice Chair. So, Dr. Elizabeth, I understand you did have some folks look at the air movement issues, and you also determined that the epidemiology didn't align with the theory that Mr. Elfstrom is putting forward. So on that, let's just have that.
I thought we weren't asking members of health. I thought we were not. We were past the point of asking.
Councillor, so we had a motion to receive. Did we not? Okay, I'll get the motion to receive of Mr. Elstrom's presentation. Thank you. Go ahead, Vice Chair. Follow through.
No, when I was going to ask a member of staff a question, I thought we were advised that.
Yeah, you're quite correct. So you go ahead, follow through, get the motion to receive.
Moved by Councillor Ferguson, seconded by Councillor Farr. Motion to receive Mr. Elston's presentation. I'm just seeking clarification from what you're suggesting, sir.
I'll just ask under other business. Thank you.
The vote is before you, Vice Chair.
Okay, everyone's able to vote?
Looking for Councillors Danko, Jackson, Nan, and Wilson.
All right. No, sorry, I'm just not following.
Thank you. So again, I'm under other business category. I'm going to ask a question of staff. Is that appropriate? Madam
That
Clerk?
vote carries. Sorry, just trying to get the vote part
Sorry,
finished.
sorry,
That
my
vote
apologies.
that vote carries 13-0. At this time, if you wish to give staff direction or ask questions, this would be appropriate as the questions have now been received.
Thank you very much. And so back to the issue of air quality in buildings, and especially Rebecca, you Dr. Elizabeth, made a determination that the epidemiology didn't match or didn't line up with some of the theories that Mr. Elstrom had put forward in terms of air quality in the building or how air moves. So have we looked at that? You know, obviously, you know, we're a little hard pressed to look at every building in our city. We have, I have to imagine, hundreds of other buildings that are not having outbreaks or having air quality issues. And so what did we look at Rebecca or the other buildings? And the epidemiology determined what?
Through you, Mr. Mayor, we did go through the whole person, place, and time, look at all of the, in every outbreak, we do this, look at what is going on, what might be the reasons for transmission. We talked to all the cases who were involved, talk to the people responsible for the sites about what is going on, and look at what seemed to be the primary contributors to spread in those circumstances, and then look to address those. So, you know, looking at issues of ventilation was certainly part of that, and that is why we did speak to our colleagues who have had other high-rise outbreaks in London, in Peel, and in North Bay, and what their experience was, what theirs looked like, how did ours differ from those circumstances. We did reach out again to Public Health Ontario, who is our source of expertise around these issues, and they had previously brought in somebody from University of Toronto, the person that Jordan mentioned earlier, Dr. Siegel, and had consultation with him. He had some presentations he had done, and so we reached out to him as well as a specific consultation on these issues. He did discuss many of the issues that David Evstrom, the presenter, just raised around, you know, how air flows, what does lead to transmission, what may not, might work against transmission, and what sort of circumstances to look at. And we're advised very much to follow what we saw and what information we collected, which did look at those issues of transmission within units. We know within households, we know within units that is where we see the highest risks of transmission. And specifically, as Michelle has already talked about, in terms of looking at the determinants of health and the number of people per unit, it can be very difficult to effectively isolate from other people in your household. We see that in single dwellings. We see that in many settings across the city. At the same time, we were also made aware of some of the issues in terms of vertical movements that have been raised around stacks and that sort of thing. And so we did advise the building management to review their ventilation systems as well as the issues related to the stacks and make sure that those were sealed, that plumbing issues were, or sorry, that ventilation issues were optimized. And we did that with all of those sites. And so we'll continue. We do that routinely. It's been our advice around ventilation and those issues, and we'll continue to do that.
Thank you. And to date, so is there any evidence that the air movement in the building has been a cause for this outbreak?
Through you, Mr. Mayor, the primary methods of transmission that we see are the ones that we have talked about. They are about in-unit spread. So that would be about, you know, it moving, you know, the whole 6-foot rule and the issues that we see there, masking, the need for masking, all of those sorts of things. We have seen other pieces in terms of going from unit to unit in terms of support, and those sorts of those issues are the main reasons, and that is, you know, continues to be why the primary pieces, and this is what Dr. Siegel said with us, this is what PHO says with us, the primary things you look at are those primary ways that spread is occurring, and that you look at physical distancing, masking, those different pieces as the primary ways to reduce spread. As always, try and optimize ventilation to reduce that any impact that that's having, but that is not the primary piece.
Okay, thank you. I'll take the chair back. Thank you very much. Councillor Wilson.
Thank you. If I could continue to ask Dr. Richardson. Dr. Richardson, the elephant in the room is, it's been raised throughout the day. It was raised last week. It's been raised on various mediums. Would you care to take this opportunity to set out publicly what limitations, how would you respond to the call by some of our delegates and others that we've reached the point where we need on-site vaccinations, starting with those high-rise buildings that have outbreaks? Would you like to speak to inform us of some of the challenges in so doing or the opportunities? I'll leave it to you, please. Thank you.
Through you, Mr. Mayor. So in terms of the piece about vaccinating on site in each of the apartment buildings throughout the city, it is, you know, the experience that we had with the residents committee at Rebecca Towers is exactly what we would want to have, which is, you know, working cooperatively to encourage vaccination, encourage the routes of vaccination that are available to people, letting us know what the challenges and barriers are to vaccination, and moving forward in that regard. In order for us to move forward with vaccinating the 550,000 people that we need to vaccinate across Hamilton, we need a variety of methods. We need a variety of methods to move forward quickly in terms of vaccinating people. We need a variety of methods in order of making vaccine available where people are comfortable and accessible in terms of being vaccinated. And we need a variety of methods to address the access issues that are raised. And so we're providing a suite of different options that are available, the mobile clinics that are targeted towards those who have challenges around access, either due to location or because they don't feel comfortable where they're vaccinated. They want to be in a setting that is more familiar, and so we are doing those things. We have our mass vaccination clinics as well that are going forward and vaccinating over 4,000 people every day. And by far, that is the most efficient and effective means in terms of vaccinating people. It continues to be. We continue to see high levels of bookings in those through those routes. We're not seeing that drop off. We offer 7 days a week, appointment times, day and evening. And as you heard from Michelle, we continue to look as we move through the essential workers population. Are there times of day that might be even better in terms of vaccinating? And then for those people who aren't able to come to the vaccine or to a site that is available throughout the city, we do look at homebound vaccination through our EMS folks. Very labor intensive and very challenging. There are a number of factors we need to look at in standing up any particular clinic. So it takes us a couple of weeks to stand up any particular clinic site. And of course, it's easier to go back to a site than one that is either a city operated site or one that we've already had in the past, because they have to be inspected, any repairs made. There's a number of things that have to be set out. Moving our vaccine from place to place is challenging. These vaccines do not move easily. They have a lot that needs to be put in place in terms of maneuvering them, and it's quite labor intensive just from that perspective as well. Nonetheless, we do, and we bring them out to different places, but it also increases the amount of wastage that we're at risk for, as well as that we experience when we're doing these very small clinics that have, say, 85 people being vaccinated. That's 9 vials of Moderna and 5 doses of Moderna that will be wasted in order to vaccinate that number of people. And so if you think of a larger clinic, we're not going to be having that happen as well. So there's all sorts of reasons why we've tailored it the way we have. And certainly when we're looking at timeliness and for places that are in outbreak, still having people move to those sites when they're able to do that is a more timely way of getting it there. To set up a pop-up clinic would take a long time. I know the term pop-up makes it sound like we can do it in a day, but it takes 2 to 3 weeks to get these set up, if not longer. And so much quicker to go to clinics, to extend the hours at a clinic where we can have staff stay on, work some overtime, and have people come through, and then focus for those who cannot leave using the homebound strategy, which even still has a significant number of challenges in terms of people actually being there, opening the door when we do use that strategy. So we'll continue to look at ways we go forward. We're also trying to get this vaccine into primary care providers, more pharmacies, all of those things. We know from the influenza program that that is the way that most people get their vaccines, and that provides the greatest access. And so the province is working on that on the pharmacy front. That's directly operated through them, and we're continuing to work on that with all of the care providers in Hamilton. So if they have as we go forward with primary care and all the places that the universal influenza program is run through, you'll see an increased number of sites that happen throughout the city. And as we go forward as well, when there's proposals that come forward that address all of those things I just talked about in terms of the site, the staffing issues, all of the vaccine handling, those kind of pieces, we entertain them whenever they come forward. Oftentimes we find when people do come forward, when they realize they need to use the IT system to do it, when there's all of those pieces to it, that they don't want to move forward any further with and they leave it in our hands. But we're absolutely happy to work with, and we have worked with groups in terms of proposals to move forward in other ways.
Thank you. Councillor Knapp? Yeah, and then Councillor Farr, and then Councillor Clark. Go ahead,
Sorry,
Councillor.
I was just surprised through you, Mayor, at the speakers list. I know that Councillor Farr had an outstanding question, and I'd be happy to cede and let him go first and come to the end.
That's great.
Oh, no, he's waving. Okay. So thank you through you. At this point, I just wanted to raise the piece about prevention of outbreak in our apartment buildings. Dr. Richardson, we had the opportunity to talk over the weekend, and I just wanted to get clarity from you or anyone else in EOC about whether or not we're looking at an approach that does targeted campaign of information to our apartment buildings, and whether or not we have a roster of lists that exist to this municipality and to public health that identify all the property owners and or apartment building property managers to ensure that that information is getting into the hands of our residents in a form that is not digital, and to ensure that that information doesn't just direct people to a digital platform, but that enables them to, where the digital divide exists, access that information by a phone call.
Doctor?
Through you, Mr. Mayor. So when we're working with apartment buildings like the ones that we've worked with this weekend, absolutely, we're looking at different ways of giving out information. As you heard in these cases, there's different ways we deal with cases one-on-one. There's ways we go out with the Rebecca group with the vaccine ambassadors, and they'll be going out to the other sites and giving information in different ways with translated resources and those sorts of things. But as well, you've heard a little bit, there's been a little theme about WhatsApp, and particularly when it comes to some of the digital challenges, we do find that many people are using that access rather than social media, rather than broader media, to access information through that way. And we're looking at how we can expand upon that as we go forward.
And through you, on the question about a roster of names of apartment building owners that public health can access to get that information out through those channels?
Through you, Mr. Mayor, that's a piece, Councillor, from our conversation that I need to follow up on. We certainly would not have a list of all apartment buildings. I don't know to the extent to which MLE or those groups would have a list of all apartment buildings. We certainly have those for congregate settings like residential care facilities, retirement homes, nursing homes, homes for special care, all of those that we work with, and we've sent information through on a regular basis. But in terms of looking at that from an apartment perspective, we'd need to look at that further.
Thank you.
Thank you. Councillor Farr?
Yeah, Mr. Mayor, just from the airflow side, I don't think I will knee-jerk a motion, but I definitely will be following up. And based on some of the answers you received in your questions to staff on some of the comments and concerns and expertise that the final delegate brought forward on this issue, but hearing confirmation from Dr. Richardson that both Public Health Ontario, their consultant, I guess, Dr. Siegel, are highly focused on the optimal ways to reduce spread is those primary ways, as Dr. Richardson said, and that has a lot to do with the socialization and the social distancing and those things. That said, important that Dr. Richardson did re-emphasize how tough that is to stay clear of those folks who are in your household, particularly in smaller footprints, I would assume, of apartment buildings. And as I've said publicly in the past, the smaller corridors, public spaces, the one elevator and those sorts of things that they're dealing with specifically at 235. That all said, Mr. Mayor, Dr. Richardson also said that public health or city officials ordered the building manager to address ventilation deficiencies that they did find. at 2:35. And when I heard that, immediately I think about all those calls all of us make every day to, MLE and in particular areas of municipal law enforcement. And I wonder always about how will we follow up? If we're leaving it in the hands of, in this case, the property owner, like we do on most property standards issues as an example, where do we fit in terms of making sure the ventilation issues are addressed? And what expertise are we using when we order these building managers, and in this case and others going forward, I suspect, to address ventilation issues? All of that said, Mr. Mayor, I get it. I don't think I will offer a motion at this time, but I certainly will be following up, and maybe at the next update from health that we receive in terms of our agendas here, we could hear something to that end. I'll ask that of Dr. Richardson, but not expecting an answer right now, given we want to be privy to time. And finally, I do have to follow up because I've just learned when I heard the other delegate earlier, Emily, mentioned that the vaccine teams weren't knocking on doors. She did say that it was that's what she learned from the people she spoke to. The people she spoke to must have been those actually with COVID-19, because we told our vaccine ambassadors not to knock on those doors. All other doors at 2:35 were knocked on. Thanks, Mr. Mayor. Thank you, Dr. Richardson, and thanks to my colleagues for a wonderful conversation today. All important things.
Thank you. Councillor Clark?
Thank you, Mr. Mayor. I'm just trying to get some. Thank you. I'm just trying to get some clarity. So airflow in apartment buildings is not the primary source, is what I heard Dr. Richardson say, or paraphrase what Dr. Siegel said. So is airflow in the older buildings a source of COVID-19 infection? Can it be a source?
Doctor?
Through you, Mr. Mayor, in discussing with Dr. Siegel and with Public Health Ontario, there are outbreaks where it has been identified as being a source, primarily in the ways that you heard Mr. Efstrom speak to. And so it can be in those ways. Of course, we also know that airflow, in terms of how we're close to one another and those sorts of things, that's a part of the role of droplet spread when we're in near proximity, which is the piece I was talking about in terms of within apartment unit dwellings. So it has been seen, and that is where the advice that we had from both the engineering side and the Public Health Ontario side was follow what you see in terms of person, place, and time. Look at what the connections are between people, how transmission might be occurring, and then follow from that.
And is there a scientific test that can be utilized to see if the airborne contagions are moving between apartments, or is it epidemiological tests in terms of following the patterns and behaviors of humans in the apartment building?
Thank you. Doctor?
Through you, Mr. Mayor. And if I might, I'm going to just raise the one point I wanted to clarify, and then I'll come back to answering Councillor Clark's question. I'm sorry, Councillor Clark.
It's okay.
Councillor Clark, I just wanted to be clear in reviewing what we did at Rebecca Towers. We did not see any specific deficiencies in terms of ventilation, but we did want to make sure that it was optimized and that those particular roads that Mr. Efstrom has raised were looked at in terms of the building status, and we've asked them to do that. We did not order them to do that. We've asked them to do that, and we've asked them to report back to us on their findings.
Thank you.
Councillor Clark, coming back to the question about what is the test to look at it, our discussions with our engineer colleague is that that's very difficult to do. It's very difficult to find somebody who can address both the ventilation side and the infectious disease side of transmission. It is very challenging. He didn't have particular experts to recommend who had that expertise, but rather had given us the overall advice back in terms of what's been seen, what are the situations where that has been a case where it has happened, and the advice that in each case everybody should be looking at how to maximize ventilation, how to ensure those kinds of air transmission gaps that Mr. Efstrom talked about with stacks were looked at, reviewed in those settings, and to otherwise continue to look at what the pattern of spread was based on the epidemiology that is seen in each instance, the person, place, and time.
Councillor Clark?
So given that airflow may be a source, but not a primary source in apartment buildings, at what point or what positivity rate in an apartment building would become the threshold for public health to say we need to go in and do vaccinations on that building?
Doctor?
Through you, Mr. Mayor. So each circumstance gets addressed individually. And so what we are looking at is how do the rates compare with background rates? There are cases happening all across the city. There are cases happening in single dwellings, in residential care facilities, in retirement homes that have occurred. There are cases that are happening in apartment buildings. And we are just looking at, the threshold associated with those and just where would we say it's something that's of a greater concern in law. You've seen us do it with these particular buildings, and we'll continue to look at it and see where it is and then make decisions based on what we see.
Thank you.
So there isn't a specific positivity number that would trigger, say, 40% of the building has it. We have to go in and do vaccinations now. We don't have a set threshold.
Through you, Mr. Mayor, I just want to address the positivity number versus the case number. We don't know the total number of people who get tested and don't have an address by address positivity rate. In terms of looking at the city, what we have is the number of cases that we have. So that's anybody who would have been positive and has tested and has their primary address in Hamilton, or gets referred to us. And so that is what we review, and we don't have a specific threshold. What we do is look at each circumstance and look at what is happening in that circumstance, the epidemiology of the particular characteristics there, and make a decision based on what we see.
Thank you. Ms. Clark?
Thank you. That's all for my questions. Thank you, sir. I won't provide any comments today. Thank you.
Thank you. And so I see no further questions. I'll take a motion to adjourn. Moved by Councillor Pauls, seconded by Councillor Vanderbeek. All in favor? Thank you, staff, for your fortitude to continue to work through these issues. Much appreciated. All of our staff and the entire teams that are working on this on an ongoing basis and when you're ready to put up the vote, Madam Clerk, I'll be ready to put my finger to a yes. Did I catch you by surprise?
The vote is up.
There you go.
Pardon the delay.
No problem. Very much. And thank you to Stephanie and Lauren for your good work. And thank you to members of council for your ongoing concern for our citizens' well-being. We all share that, and we want to do the very best possible to make sure everyone gets vaccinated and stays healthy. And
That
we'll
vote carries 12-0. Mr. Mayor.
Thank you very much. Thank you. And off to Public Works for those that are attending. Thank you all. Have a wonderful afternoon.